PEBC Study Guide genre, medical target audience, pharmacy students, interns, and international pharmacy graduates, IPGs, seeking Canadian licensure. Introduction. Navigating the road to Canadian pharmacy licensure. 0 hours 0 minutes and 11 seconds, Chapter 1. Blueprinting your study strategy. 0 hours 10 minutes and 26 seconds, Chapter 2. Essential biomedical sciences and calculations. 0 hours 22 minutes and 49 seconds, Chapter 3. Cardiovascular and Respiratory therapeutics. 0 hours 38 minutes and 45 seconds, Chapter 4. Endocrinology and metabolic disorders. 0 hours 52 minutes and 23 seconds, Chapter 5. Neurology, psychiatry, and pain management. 1 hour 7 minutes and 35 seconds, Chapter 6. Infectious diseases and immunology. 1 hour 20 minutes and 39 seconds, Chapter 7. Gastrointestinal, renal, and special populations. 1 hour 34 minutes and 47 seconds, Chapter 8. Canadian pharmacy law and jurisprudence. 1 hour 47 minutes and 37 seconds, Chapter 9. Medication safety and professional practice. 2 hours 1 minute and 12 seconds, Chapter 10. Conquering Part 1 MCQ test-taking tactics. 2 hours 16 minutes and 24 seconds, Chapter 11. Mastering Part 2 OSCE clinical skills. 2 hours 27 minutes and 10 seconds, Chapter 12. The final review and exam day logistics. 2 hours 37 minutes and 8 seconds, conclusion. Entering the profession. 2 hours 47 minutes and 40 seconds. Introduction, navigating the road to Canadian pharmacy licensure. Sections. Section 0.1, the PEBC landscape, demystifying the qualifying exam parts 1 and 2. Section 0.2, bridging the gap, adapting international expertise to Canadian standards. Section 0.3, the mindset of a licensed pharmacist, professionalism and ethics. Section 0.4, how to use this guide, leveraging visual aids and active recall. Welcome to the final stretch of your journey toward becoming a licensed pharmacist in Canada. If you are holding this book, you have likely spent years studying pharmacology, medicinal chemistry, and therapeutics. You have sacrificed weekends, navigated complex rotations, and committed yourself to a life of healthcare service. However, the path to licensure in Canada, specifically passing the Pharmacy Examining Board of Canada, PEBC, qualifying exam, requires more than just textbook knowledge. It demands a shift in identity. You must transition from a student who absorbs information to a practitioner who applies it to protect patients. This chapter is your orientation. We aren't just looking at what to study, we are examining how to think. Whether you are a Canadian graduate or an international pharmacy graduate, IPG, the standard is the same: safety, competency, and effective communication. Let's map out the terrain ahead. 0.1 The PEBC landscape, demystifying the qualifying exam parts 1 and 2. The PEBC qualifying exam is a beast with two distinct heads. Many candidates make the mistake of treating them as a single entity, but they require fundamentally different cognitive approaches. Understanding the mechanics of each part is the first step toward conquering them. Part 1, MCQ, is a test of your knowledge base and clinical reasoning. It asks, do you know the guidelines, and can you select the best therapy based on evidence? It is an endurance test of mental stamina, requiring you to sift through distractors to find the most appropriate answer, not just a correct one, but the best one for that specific patient context. Part 2, OSCE, is a test of your performance and professional behavior. It asks, can you communicate that knowledge safely to a human being? In the OSCE, Objective Structured Clinical Examination, you are an actor on a stage where the script is written in real time. You must demonstrate empathy, manage conflict, and catch drug therapy problems, DTPs, while the clock ticks down. Figure, extra detailed AI-ready prompt for AI-generated diagram showing a split-screen infographic. On the left, labeled a Part 1, the archive, show a stylized brain interconnected with books, guidelines, and a multiple-choice sheet, represented in cool blue tones. On the right, labeled a Part 2, the interaction, show a pharmacist speaking with a patient in a consultation room, with speech bubbles highlighting empathy, safety check, and a recommendation, represented in warm orange tones. The two sides should be connected by a bridge labeled clinical competence. The blueprint strategy. The PEBC does not hide what they are testing. The examination blueprint is public knowledge, yet many students skim over it. We will use the blueprint as our compass throughout this guide. If the blueprint dictates that a significant percentage of questions focus on cardiovascular or respiratory systems, your study time must reflect that math. We do not aim for perfection in obscure rare diseases, we aim for mastery in the conditions that affect the majority of Canadians. Feature Part 1, MCQ, Part 2, OSCE. 0.2 Bridging the Gap, Adapting International Expertise to Canadian Standards. For our international pharmacy graduates, IPGs, the challenge is often nuanced. You possess the scientific expertise, chemistry and physiology are the same globally, but the application of that science is culturally and legally specific to Canada. Pharmacy in Canada is highly patient-centered and collaborative. The pharmacist is not just a dispenser but a primary care provider with a growing scope of practice. You are expected to question prescribers when necessary, adapt prescriptions, and engage in shared decision-making with patients. The Canadian dialect of the pharmacy. Think of this transition like learning a dialect. You speak the language of medicine, but you need to learn the local idioms. In Canada, we rely heavily on specific guidelines, e.g., Hypertension Canada, Diabetes Canada, Thrombosis Canada. If you answer a question based on guidelines from your home country or general European to American standards, you may get the answer wrong in the eyes of the PEBC. This guide prioritizes Canadian-specific resources and scope of practice. Figure, extra detailed AI-ready prompt for AI-generated diagram showing a bridge of adaptation. On one side, a pile of books labeled Global Pharmacology Knowledge. On the other side, a Canadian flag and a pharmacy counter. The bridge connecting them is supported by three pillars labeled NAPRA Standards, Canadian Guidelines, and Patient-Centered Communication. A silhouetted figure is walking across, transforming from a student to a professional. Overcoming that authority gap. In some educational systems, the physician's word is final. In Canada, you are the medication safety gatekeeper. You must be comfortable respectfully challenging a doctor's order if it endangers the patient. This requires assertiveness wrapped in professionalism. We will practice scripts and phrasing that allow you to intervene decisively without being abrasive. This is a critical skill for the OSCE. 0.3 The mindset of a licensed pharmacist, professionalism and ethics. To pass the PEBC, you must stop thinking like a test taker and start thinking like a licensed pharmacist. A test taker looks for tricks, a pharmacist looks for patient safety. When you read a case study, your first instinct should be, is this patient safe? If there is a severe drug interaction, an allergy, or a contraindication, that is your priority. Everything else, counseling on side effects, lifestyle changes, is secondary to preventing harm. The NAPRA Compass. The National Association of Pharmacy Regulatory Authorities, NAPRA, sets the standards we live by. Professionalism isn't just about wearing a white coat, it is about ethical decision-making. Are you acting in the patient's best interest? Are you maintaining confidentiality? Are you staying within your scope? These questions are the undercurrent of every exam question. Figure, extra detailed AI-ready prompt for AI-generated diagram showing a flow chart titled The Hierarchy of Clinical Decision-Making. At the top, a large red stop sign shape labeled Immediate Safety Red Flags. Below that, a yellow triangle labeled Efficacy or Guideline Adherence. At the bottom, a green circle labeled Patient Preference Adherence. Arrows flow downwards, indicating the order of priority a pharmacist must process information. Embracing this detective role. Pharmacists are clinical detectives. We look for the missing pieces, the over-the-counter drug the patient didn't mention, the kidney function that wasn't checked, or the lifestyle factor that makes a drug inappropriate. This guide encourages you to adopt this investigative mindset. Don't just memorize the drug interaction, understand the mechanism so you can predict it in a novel scenario. 0 point for how to use this guide, leveraging visual aids and active recall. This book is designed to be a tool, not a passive read. You cannot learn to swim by reading a book about water, and you cannot learn pharmacy by passively highlighting text. We utilize a visual-heavy approach because the human brain processes images 60,000 times faster than text. The diagrams in this book are not decoration, they are encoded summaries of complex pathways. The strategy of active recall. When you encounter a review checkpoint or a case study in this book, pause. Do not look at the answer immediately. Force your brain to retrieve the information. Cover the solution. Verbalize your answer. Actually speak it out loud, this preps you for the OSCE. Compare and correct. Navigating the visuals. Each chapter contains flowcharts for disease management and drug tables for rapid comparison. Use these for your final review. If you can reproduce the logic of the flowchart on a blank piece of paper, you own that knowledge. Figure, extra detailed AI-ready prompt for AI-generated diagram showing a circular cycle titled The Active Study Loop. Step 1, an icon of an eye scanning a page labeled Review Concept. Step 2, an icon of a person with a thought bubble labeled A Test Recall. Step 3, an icon of a hand writing on paper labeled Apply to Case. Step 4, an icon of a light bulb labeled Reflect and Correct. The cycle repeats, emphasizing iterative learning. We have also included red flag icons throughout the text. These indicate high-stakes safety issues that are frequent flyers on the PEBC exams. When you see a red flag, pay double attention. You are about to embark on a challenging but rewarding process. Trust your training, respect the Canadian standards, and use this guide to sharpen your focus. Let's get to work.
Chapter 1. Blueprinting Your Study Strategy. Sections. Section 1.1. Decoding the PEBC Syllabus and Weighting Clinical Topics. Section 1.2. Creating a Realistic Study Timeline, from 6 months to 6 weeks. Section 1.3. Curating Your Library, Essential References and Canadian Guidelines. Section 1.4. Evidence-Based Study Techniques, Spaced Repetition and Interleaving. Section 1.5. Balancing Life and Licensure, Managing Burnout and Exam Anxiety. Chapter 1. Blueprinting Your Study Strategy. In the introduction, we discussed the necessary shift in identity from student to practitioner. Now, we must build the infrastructure to support that shift. Passing the PEBC qualifying exam is not merely a test of intelligence, it is a test of strategy, endurance, and resource management. Many brilliant candidates fail not because they lack knowledge, but because they lack a battle plan. They dive headfirst into massive textbooks without understanding the terrain. This chapter is your architectural blueprint. We will strip away the noise and focus on the structural elements required to pass, understanding the exam metrics, managing your time, selecting the right tools, and optimizing your cognitive retention. Let's turn your ambition into a calculated, actionable strategy. 1.1 Decoding the PEBC Syllabus and Weighting Clinical Topics. Figure, a clean, architectural-style blueprint schematic titled the PEBC Strategy Matrix. The visual is divided into 4 quadrants: syllabus decoding, top left, timeline management, top right, resource curation, bottom left, and cognitive endurance, bottom right. The lines are white on a blueprint blue background, with technical annotations highlighting the interconnectivity of these 4 pillars. The PEBC syllabus is more than a list of topics, it is a risk assessment map. The board is transparent about what matters most, yet many students spend disproportionate amounts of time on low-yield subjects. To study efficiently, you must think like an examiner. The exam assesses competency in 9 major areas, but they are not weighted equally. Biomedical sciences might feel foundational, but clinical sciences, therapeutics, form the overwhelming bulk of the exam. If you master pharmacokinetics but fail to manage hypertension or diabetes, you will not pass. You must prioritize high-impact systems. Cardiovascular, respiratory, endocrine, and neurology psychiatry are the pillars of the exam. These topics are dense, guideline-heavy, and frequent in both MCQ and OSCE stations. Conversely, topics like dermatology or ophthalmology, while important, carry less statistical weight. This doesn't mean you skip them. It means you allocate your energy effectively. You do not want to be the candidate who knows everything about glaucoma drops but blanks on a myocardial infarction protocol. Weighting strategy. Review the following weighting distribution. This is a general approximation based on historical PEBC blueprints and competency profiles. Use this to budget your study hours. Domain category approximate weighting strategic priority. Figure. A 3D heat map visualization of the human body and a pharmacy shelf. The heart, lungs, and pancreas are glowing bright red, indicating high priority high weighting, while the skin and eyes are shaded in cool blue, lower weighting. Overlaying text shows percentages corresponding to PEBC clinical weighting, emphasizing where the heat of the exam lies. 1.2 Creating a realistic study timeline, from 6 months to 6 weeks. A timeline is your accountability partner. The scope of Canadian pharmacy practice is too vast to cram effectively. Your timeline depends heavily on your background, whether you are a current Canadian student or an international pharmacy graduate, IPG, and your current life commitments. We will look at two distinct approaches, the standard marathon, 6 months, and the intensive sprint, 6 to 10 weeks. Regardless of the duration, your timeline must include 3 distinct phases: content review, application practice, and simulation. The 6-month marathon, recommended. This schedule allows for deep learning and life balance. It is ideal for IPGs who may need to familiarize themselves with Canadian-specific guidelines or students working part-time. Months 1 to 3, foundation review 1 body system per week. Focus on pathophysiology and first-line therapies. Read the guidelines thoroughly. Months 4 to 5, application switch to solving cases. Do not just read, answer questions. Start mixing topics, e.g., a patient with diabetes and asthma. Month 6, simulation-timed mock exams only. Replicate exam conditions. Wake up at the same time the exam starts. Build your stamina. The 6-week sprint, high risk, high intensity. This is for the student who has just finished rotations or the retaker who is already close to passing. It requires 6 to 8 hours of focus study daily. Weeks 1 to 3, triage focus strictly on the big 4, cardio, resp, endo, psych. Skim the rest. Use condensed notes rather than full textbooks. Weeks 4 to 5, rapid fire do 100 plus MCQs a day. Review only the rationales for questions you got wrong. Week 6, taper review ethics, law, and drug calculations. Rest your brain 2 days before the exam. Figure, a horizontal Gantt chart graphic spanning 6 months. The chart uses color-coded bars to represent knowledge acquisition, blue, case solving, green, and mock exams, orange. The sprint version is overlaid below as a compressed, high-intensity version with red alert icons indicating high daily hourly requirements. The visual style is clean, modern, and easy to read. 1.3 Curating your library, essential references and Canadian guidelines. One of the biggest pitfalls for IPGs is relying on resources from their home country or the United States, like NAPLEX books. While the physiology of a heart attack is the same globally, the treatment algorithms are not. The PEBC tests on Canadian practice. You must curate a library that mirrors what you will use in practice. Throwing money at every study guide available leads to paralysis. You need a gold standard source for therapeutics and a reliable summary resource for rapid review. The core Canadian arsenal. Compendium of Therapeutic Choices, CTC for minor ailments. This is your Bible. If the CTC says a drug is first line, it is first line on the exam, even if a new study came out yesterday suggesting otherwise. Compendium of Pharmaceuticals and Specialties, CPS RxTX. You do not read this cover to cover. Use it to look up specific drug interactions, dosage forms available in Canada, and black box warnings. NAPRA drug schedules. You must know which drugs are Schedule 1, RX, 2, behind the counter, or 3, self-selection. This is unique to Canada. Secondary resources. Guideline bodies. Bookmark the websites for Diabetes Canada, Hypertension Canada, and the Canadian Thoracic Society. Guidelines update faster than textbooks. Moral ethical frameworks. Review the code of ethics from your provincial college, e.g., OCP, ACP. The exam assumes a generic national standard, but these documents provide the language of professionalism. Author's note: be careful with US-based resources. Blood pressure targets and diabetes cutoffs often differ between the US and Canada. When in doubt, default to the Canadian guideline. 1.4 Evidence-based study techniques, spaced repetition and interleaving. Reading a chapter and highlighting text is the most common and least effective way to study. It creates the illusion of competence. You recognize the text, so you think you know it. To pass the PEBC, you need active recall. We will leverage two cognitive science principles, spaced repetition and interleaving. These techniques are difficult because they force your brain to work harder, but the retention payoff is massive. Spaced repetition systems, SRS. The forgetting curve is steep. If you study heart failure on day 1 and don't review it until day 30, you will have forgotten 80% of it. SRS forces you to review information at increasing intervals, 1 day, 3 days, 1 week, 1 month. Use digital flashcard tools, like Anki, or a manual Lightner box system. The goal is to review material just as you are about to forget it. This struggle to retrieve the memory strengthens the neural pathway. Interleaving, the art of mixing. Traditional studying is blocked. You study cardiology for 3 days, then move to GI. This is comfortable, but it is not realistic. Patients do not present in blocks. Interleaving involves mixing related topics during a single study session. Study hypertension for an hour, then switch to renal failure, then do a law ethic case. This forces your brain to constantly discriminate between different types of problems, which is exactly what the exam, and real life, requires. Figure, a split-screen comparison diagram. The left side shows a blocked study approach as neat, isolated stacked cubes of single colors, red, blue, green. The right side shows interleaved study as a woven fabric where the colored threads cross over each other, creating a stronger, unified mesh. Labels explain that the woven approach represents stronger memory retention. 1.5 Balancing life and licensure, managing burnout and exam anxiety. Let's address the elephant in the room. This process is exhausting. Many of you are working full-time, supporting families, or navigating the immigration process while studying. Burnout is a real threat that can derail even the best timeline. Exam stamina is a physical trait, just like running. If you are constantly flooded with cortisol, stress hormone, your prefrontal cortex, the part of your brain responsible for logic and decision-making, shuts down. You cannot critically analyze a clinical case if you are in fight or flight mode. The anti-burnout protocol. Protected rest. Schedule your breaks as strictly as your study time. A guilt-free evening off is more productive than 3 hours of staring blankly at a page. Simulation of stress. Anxiety spikes when we face the unknown. By simulating the exam environment, no phone, timed blocks, hard chair, you desensitize yourself to the stress triggers of exam day. Find your why. When the guidelines get boring, remind yourself of the patient. You are not memorizing a dose, you are learning how to keep a grandmother safe or how to help a child breathe. Connect the data to the humanity of the profession. You are capable of this. The PEBC is a hurdle, not a wall. By building this blueprint, decoding the syllabus, setting a timeline, curating resources, and respecting your own mental health, you are taking control of the outcome. In the next chapter, we will dive into the core of the exam, mastering the biomedical sciences without getting lost in the weeds.
Chapter 2, Essential Biomedical Sciences and Calculations. Sections, Section 2.1, Pharmacokinetics Fundamentals, Absorption, Distribution, Metabolism, and Excretion, Section 2.2, Mastery of Pharmaceutical Calculations, Allegations, Osmolarity, and Milliequivalence, Section 2.3, Bioavailability and Bioequivalence, The Science Behind Generics, Section 2.4, Microbiology Basics for the Pharmacist, Pathogens and Resistance Mechanisms. In Chapter 1, we designed your study architecture. Now, we must pour the concrete foundation. Many candidates make the fatal mistake of skimming over biomedical sciences, assuming their knowledge from early pharmacy school years is sufficient. However, the PEBC does not test these concepts in isolation, it tests your ability to use them as diagnostic and problem-solving tools. You cannot effectively adjust a dose without understanding renal clearance, pharmacokinetics, nor can you safely mix and bag without mastering osmolarity calculations. This chapter is not a mere review of biology or algebra. It is a recalibration of those basic sciences into clinical weapons. We will bridge the gap between abstract theory and the patient standing in front of you. Let's master the essentials. Figure, detailed infographic illustration titled The Pharmacist's Foundation. The image shows a cross-section of a building foundation. The bottom layer is labeled Biomedical Sciences, the middle layer are Calculations and Kinetics, and the top structure is Clinical Therapeutics. The visual style is clean, vector-based, utilizing medical blues and grays, highlighting how clinical decisions rest upon these scientific pillars. 2.1 Pharmacokinetics Fundamentals, Absorption, Distribution, Metabolism, and Excretion. Pharmacokinetics, PK, is the story of what the body does to the drug. For the licensing exam, you must move beyond memorizing definitions to predicting outcomes. When a patient's physiology changes, due to age, disease, or interaction, the PK profile shifts, and safety hangs in the balance. We conceptualize this journey through the acronym ADME. Every clinical decision regarding dosing intervals or route of administration goes back to these four pillars. Absorption, crossing the threshold. Absorption is the movement of a drug from its site of administration into the central compartment, usually the bloodstream. This process is dictated by the drug's pKa and the pH of the environment. Remember the rule of thumb, like dissolves like. Weak acids absorb best in acidic environments, stomach, while weak bases favor the alkaline environment of the small intestine. However, practically speaking, the vast surface area of the small intestine makes it the primary absorption site for most oral drugs, regardless of pH. Factors like gastric emptying time significantly alter the Tmax, time to peak concentration. Prokinetics speed it up, anticholinergics slow it down. If you need rapid onset for pain relief, a delayed gastric emptying time becomes a clinical failure. Distribution, the bus ride. Once in the blood, the drug must travel to tissues. This is where volume of distribution, VD, and protein binding become critical. Think of albumin as a bus, drugs bound to albumin are on the bus and inactive. Only the passengers who get off, free drug, can exert an effect or be cleared. If a patient is malnourished or has liver failure, they have low albumin, fewer buses. This means more free drug is circulating, potentially leading to toxicity even at normal doses. This is a classic PEBC scenario involving highly protein-bound drugs like phenytoin or warfarin. High VD means the drug loves tissue, lipophilic, and leaves the blood, digoxin. Low VD means it stays in the blood, aminoglycosides. This dictates whether you need a loading dose to fill up the tank. Metabolism, the biotransformation factory. The liver is the primary metabolic factory, aiming to make drugs more water-soluble for excretion. The Phase 1, oxidation reduction via CYP450, and Phase 2, conjugation, reactions are your focus here. You must memorize the major CYP inhibitors and inducers. An inhibitor, like clarithromycin, acts like a dam, causing the substrate drug levels to rise to toxic heights. An inducer, like carbamazepine, opens the floodgates, washing the drug out before it can work. Figure, AI ready prompt for diagram showing the CYP450 interaction mechanism. Split screen visual. Left side shows inhibition, a blocked enzyme tunnel causing drug molecules to pile up, toxicity. Right side shows induction, multiplied enzymes shredding drug molecules rapidly, therapeutic failure. Use distinct colors, red for inhibitors, green for inducers. Professional, flat design. Excretion, the final exit. Most drugs exit via the kidneys. Clearance depends on glomerular filtration, active secretion, and passive reabsorption. The PEBC love scenarios involving creatinine clearance, CRCL, because it is the surrogate marker for kidney function. As a pharmacist, you are the gatekeeper of renal dosing. If a patient's CRCL drops below 30 ml per minute, you must instinctively check their medication list. Drugs like gabapentin, allopurinol, and DOACs require immediate adjustment to prevent accumulation. 2.2 Mastery of pharmaceutical calculations, allegations, osmolarity, and milliequivalence. Calculations are the high-stakes mathematics of patient safety. A decimal point error here is not a lost mark, it is a potential fatality. Approach this section not with fear, but with the precision of an engineer. We will focus on the three areas that most frequently trip up candidates: allegations, osmolarity, and electrolyte conversions. Allegation, the tic-tac-toe method. Allegation is used when you have two solutions of different concentrations and need to mix them to create a specific intermediate concentration. The tic-tac-toe or grid method is the most reliable way to visualize this. Imagine you have a 20% cream and a 5% cream, and you need to make a 10% cream. 1. Place the higher strength, 20, in the top left. 2. Place the lower strength, 5, in the bottom left. 3. Place the desired strength, 10, in the center. Now, subtract diagonally, always positive numbers. * 20 minus 10 is equal to 10 parts of the 5% cream. * 10 minus 5 is equal to 5 parts of the 20% cream. Total parts equals 15. The ratio is 5:10, or 1:2. For every 1 gram of 20% cream, you mix 2 grams of 5% cream. It turns complex algebra into simple subtraction. Osmolarity, balancing the tonicity. Osmolarity measures the number of particles in a solution. This is vital for 4 preparations. Blood serum osmolarity is roughly 285 to 295 mosm/L. Injecting a solution that is too hypotonic causes red blood cells to burst, hemolysis; too hypertonic causes them to shrivel, crenation. The calculation relies on the number of species a molecule dissociates into. Dextrose does not dissociate, 1 particle. NaCl dissociates into Na plus and Cl, 2 particles. CaCl2 dissociates into Ca++, Cl-Cl, 3 particles. Formula? Do not memorize the numbers blindly. Understand that ionic compounds exert more osmotic pressure than non-ionic ones. This is why normal saline, 0.9%, is isotonic, but 5% dextrose is also isotonic. The math balances out despite the weight difference. Milliequivalents, MEQ counting charges. Milliequivalents represent chemical combining power, not weight. This concept is crucial for electrolytes like potassium and magnesium. A patient doesn't need grams of potassium, they need a specific number of cations to maintain cardiac rhythm. Formula? The valence is the charge, 1 for K+, 2 for Ca++. This relationship explains why 1 mole of potassium chloride, KCl, provides 1 MEq of K+, but 1 mole of calcium chloride, CaCl2, provides 2 MEq of Cl-. 2.3 Bioavailability and bioequivalence, the science behind generics. Figure, detailed diagram of visualizing pharmaceutical math. 3 panels. Panel 1, an allegation grid with arrows showing diagonal subtraction. Panel 2, a blood vessel showing isotonic vs hypertonic effects on red blood cells. Panel 3, a scale balancing a weight, milligram, on one side and a chemical activity, MEq, on the other. Educational, clear labels, distinct color coding for each concept. In Canadian pharmacy practice, you will frequently interchange brand name drugs with generics. Patients will ask, is this cheaper version safe? Your answer must be rooted in the concepts of bioavailability, F, and bioequivalence. Bioavailability, F. Bioavailability is the fraction of the administered dose that reaches the systemic circulation unchanged. For 4 drugs, F equals 100%, or 1. For oral drugs, F is almost always 1 due to incomplete absorption and first-pass metabolism. When switching a patient from 4 to PO, e.g., ciprofloxacin or furosemide, you must account for F as ciprofloxacin has high bioavailability, 80%, so the oral dose is similar to the 4 dose. Furosemide has poor bioavailability, 50%, so the oral dose must be roughly double the 4 dose to achieve the same effect. Bioequivalence, the confidence interval. A generic drug is considered bioequivalent if the 90% confidence interval, CIO of the ratio of the generic to the brand falls within 80% to 125%. This applies to 2 parameters, 1. AUC, area under the curve total exposure to the drug. 2. Cmax, the peak concentration. This does not mean the generic can be 20% weaker or 25% stronger. It means the statistical variance is contained within that range. For most drugs, the actual difference is less than 4%. However, for narrow therapeutic index, NTI, drugs like cyclosporine, lithium, or levothyroxine, even small variances can be clinically significant. This is why Health Canada has stricter standards for certain NTI drugs, and why pharmacists hesitate to switch brands for stabilized transplant or epilepsy patients. Figure, line graph showing our bioequivalence curves. 2 curves, brand vs generic, plotted on a concentration versus time axis. The curves are nearly overlapping. Shaded regions highlight the Cmax, peak, and the AUC, area under the curve. Annotations indicate the 80 to 125% confidence interval. Professional, scientific plotting style. 2 point for microbiology basics for the pharmacist, pathogens and resistance. You do not need to be a microbiologist, but you must be a steward of antimicrobials. The PEBC requires you to match the bug to the drug. We categorize pathogens not just by taxonomy, but by the infections they cause and their resistance patterns. The big picture, gram staining. Visualizing the cell wall is the first step in choosing an antibiotic. Asterisk gram-positive, purple thick peptidoglycan wall. Think clusters and chains. Staphylococcus, skin, and Streptococcus, throat, lungs. Asterisk gram-negative, pink thin wall, outer membrane, tricky to penetrate. E. coli, UTI, Pseudomonas, hospital-acquired, H. influenzae, lungs. Asterisk atypicals, no cell wall. Mycoplasma, chlamydia, Legionella. Beta-lactams, penicillins, cephalosporins, are useless here because there is no wall to attack. Key pathogens and drug of choice thinking. Instead of memorizing lists, link the bug to the site. 1. Above the diaphragm, usually gram-positive cocci, strep pneumo. First line, amoxicillin. 2. Below the diaphragm, usually gram-negative rods, E. coli. First line, ciprofloxacin, TMP SMX, or nitrofurantoin. 3. Skin, soft tissue, Staph aureus. First line, cephalexin or clarxacillin. Mechanisms of resistance. Resistance is an evolutionary arms race. Asterisk beta-lactamases, enzymes that chew up the antibiotic ring. We fight back by adding inhibitors, e.g., clavulin is amoxicillin plus clavulinate. Asterisk altered target binding, the bacteria changes the lock so the key doesn't fit, e.g., MRSA alters the penicillin binding protein. Asterisk efflux pumps, the bacteria literally spits the drug out, common in tetracycline resistance. Understanding these mechanisms allows you to predict why a treatment failed and what to select next. If a patient has an ESBL, extended spectrum beta-lactamase, producer, you know that ceftriaxone will fail, and you must escalate to a carbapenem. Summary: building the framework. We have covered the journey of the drug, PK, the math ensuring its safety, calculations, the validation of its source, bioequivalence, and the targets it must destroy, microbiology. These concepts are the non-negotiable vocabulary of your profession. As we move into the therapeutic chapters, we will stop defining half-life or gram-negative and start applying them to save kidneys, hearts, and lives. Take a moment to review the calculation formulas and the ADME flowchart. Ensure you own these concepts. In the next chapter, we will turn our attention to the cardiovascular system, where these calculations will determine the line between stability and crisis.
Chapter 3: Cardiovascular and Respiratory Therapeutics. Section 3.1, Hypertension Management, Navigating the Canadian Algorithms, Section 3.2, Dyslipidemia and Cardiovascular Risk Assessment, Section 3.3, Heart Failure and Ischemic Heart Disease, Drug Selection Hierarchy, Section 3.4, Asthma and COPD, Differentiating Devices and Creating Action Plans, Section 3.5, Visualizing the Clotting Cascade, Anticoagulants and Antiplatelets. In Chapter 2, we poured the concrete foundation of biomedical sciences. Now, we enter the engine room of the human body. Cardiovascular and respiratory systems act as the supply chain of life, delivering oxygen and nutrients while removing metabolic waste. For the PEBC, this chapter is high-yield territory. These conditions are prevalent, the guidelines change frequently, and the drug interactions are clinically significant. You will see these topics in multiple choice questions, MCQs, regarding guideline selection, and in objectively structured clinical examinations, OSCEs, regarding device counseling and patient monitoring. We are moving from how drugs work to how to choose the right drug for this specific patient. This requires a shift from memorization to clinical judgment. Let's navigate the guidelines with the precision of a licensed pharmacist. 3.1 Hypertension Management, Navigating the Canadian Algorithms. Hypertension is often called the silent killer, but for a pharmacy student, it can be the silent confusion. The challenge isn't the lack of drugs, it's the sheer volume of options. Your goal is to navigate the Hypertension Canada guidelines to find the specific agent that fits the patient's comorbid profile. Treating blood pressure is rarely about the number alone. It is about end organ protection. When you read a case scenario, do not just look at the BP reading, e.g., 150/94 mmHg. Look immediately at the medical history. Does the patient have diabetes? Chronic kidney disease, CKD? A history of stroke? These comorbidities are your compelling indications. They dictate the starting lineup of your pharmacotherapy. Figure, extra detailed AI-ready prompt for AI-generated diagram showing a flowchart decision tree for Canadian hypertension management. The design should be clean, flat vector style with medical blue and alert red colors. Top box, patient diagnosis. Branch left, no compelling indications leading to thiazide ACEI ARB CCB. Branch right, compelling indications branching into diabetes, ACEI ARB, heart failure, specific BB ACEI MRA, and past stroke, diuretic ACEI combination. Use clear icons for heart, kidneys, and brain. The Big Four and the rules of engagement. For patients without compelling indications, you generally have 4 first-line options. 1. Thiazide-like diuretics, prefer chlorthalidone or indapamide over HCTZ for longer duration. 2. ACE inhibitors, ACEI, e.g., ramipril. 3. Angiotensin receptor blockers, ARB, e.g., candesartan. 4. Long-acting calcium channel blockers, CCB, e.g., amlodipine. Crucial clinical rule: never combine an ACEI and an ARB. They hit the same pathway, renin-angiotensin-aldosterone system, too hard, increasing the risk of hyperkalemia and acute kidney injury without adding cardiovascular benefit. If you see this combination on an exam profile, flag it immediately. The beta blocker exception. Notice that beta blockers, BB, are not first line for uncomplicated hypertension in patients over 60. They are less effective at preventing stroke in this demographic. However, if the patient has ischemic heart disease or heart failure, the BB moves from the bench to the captain's seat. This illustrates the PEBC mindset. Context changes the correct answer. 3.2 Dyslipidemia and cardiovascular risk assessment. Cholesterol management has evolved. We have moved away from simply treating to target and moved toward risk reduction. While LDL targets, e.g., less than 2.0 millimoles per liter or less than 1.8 millimoles per liter, still exist, the decision to initiate therapy is based on the Framingham Risk Score, FRS, or the presence of statin-indicated conditions. Think of statins not just as cholesterol-lowering drugs, but as plaque stabilizers. They reduce inflammation inside the vessel wall. The statin benefit groups. According to the Canadian Cardiovascular Society, CCS, guidelines, you must identify who needs a statin regardless of their FRS. If a patient falls into these categories, do not reach for a calculator, reach for the prescription pad. Clinical condition rationale management strategy. Calculating risk for primary prevention. For patients not in the table above, we calculate the FRS, low, intermediate, high. The tricky zone is intermediate risk, 10 to 20% 10-year risk. Here, we look for risk modifiers to tip the scale, positive family history, high hsCRP, or coronary artery calcium score. If these are present, we treat. If not, we emphasize lifestyle and monitor. 3.3 Heart failure and ischemic heart disease, drug selection hierarchy. Heart failure, HF, is a plumbing problem where the pump cannot meet the demand. Specifically, in heart failure with reduced ejection fraction, HFrEF, the heart is weak and floppy. Our therapeutic goal is neurohormonal blockade. The body tries to compensate for the weak heart by releasing adrenaline and activating the RAAS system, which whips the tired heart to work harder. This eventually kills the heart muscle. Our drugs stop this compensatory mechanism. The 4 pillars of survival. Modern HFrEF therapy is built on 4 pillars that have been proven to reduce mortality. On the exam, if a patient with HFrEF is not on these 4 agents, you must have a documented reason, e.g., hypertension, hyperkalemia, allergy. ARNI, sacubitril valsartan, or ACEI-ARB, vasodilation and inhibition of remodeling. Beta blockers, specifically bisoprolol, carvedilol, or metoprolol succinate. They slow the heart, reducing oxygen demand. MRA, spiralactone eplerenone prevents aldosterone-induced fibrosis. SGLT2 inhibitors, dapagliflozin, empagliflozin, originally diabetes drugs, these are now metabolic powerhouses for the heart, reducing preload and afterload. Figure, extra detailed AI-ready prompt for AI-generated diagram showing the 4 pillars of heart failure as a structural architectural diagram. 4 distinct Roman columns holding up a roof labeled patient survival. Column 1, ARNI ACEI, gold color. Column 2, beta blocker, blue color. Column 3, MRA, green color. Column 4, SGLT2I, red color. Underneath the foundation, show arrows stopping sympathetic drive and RAAS activation. Ischemic heart disease, IHD. In IHD, angina, the strategy is supply versus demand. We need to increase oxygen supply, vasodilation, and decrease oxygen demand, slower heart rate, less contractility. Short-acting nitrates, nitroglycerine, are for acute relief. Beta blockers are for prevention. Calcium channel blockers are excellent add-ons, but remember, never use non-DHP CCBs, diltiazem verapamil, with beta blockers unless you want to risk causing complete heart block. 3.4 Asthma and COPD, differentiating devices and creating action plans. Respiratory therapeutics is the area where pharmacists add the most value in a community setting. The drugs are delivered directly to the site of action, meaning the technique is just as important as the molecule. You must distinguish between the 2 diseases. Asthma is primarily an inflammatory disease, COPD is primarily a structural obstructive disease. The inhaler literacy test. In an OSCE, you will likely have to demonstrate a device. Do not gloss over this. *MDI, metered dose inhaler requires coordination. Shake, breathe out, press and breathe in slowly. Best used with a spacer, aerochamber. *DPI, dry powder inhaler breath actuated. Do not shake. Breathe out away from device. Seal lips. Breathe in fast and deep. Management differences. Asthma, the cornerstone is inhaled corticosteroids, ICS. Safety guidelines have shifted away from SABA-only treatment, like Ventolin alone, because it masks inflammation while the risk of attack grows. Preferred path, ICS formoterol as both maintenance and reliever, MART therapy. Alternative, maintenance ICS plus SABA reliever. COPD, the cornerstone is bronchodilation. Early, LAMA, long-acting muscarinic antagonist, or LABA. Progression, LAMA plus LABA combined. High risk, eosinophils greater than 300 add ICS, triple therapy. Note that we avoid ICS in COPD unless there are frequent exacerbations or high eosinophils, due to the risk of pneumonia. This is the opposite of asthma, where ICS is mandatory for almost everyone. 3.5 Visualizing the clotting cascade, anticoagulants and antiplatelets. Hemostasis is a high-stakes balancing act. Too little clotting leads to hemorrhage, too much leads to thrombosis, DVT, PE, stroke. Understanding where drugs hit the clotting cascade helps you predict interactions and reversal strategies. We generally divide agents into antiplatelets, for arterial clots, high shear flow, think white clots, and anticoagulants, for venous clot stasis, think red clots. The cascade mapped. Instead of memorizing a list, visualize the pathway. Warfarin, vitamin K antagonist. Inhibits factors 2, 7, 9, and X. It is messy, affected by diet, leafy greens, and requires INR monitoring. Heparins, UFH-LMWH potentiate antithrombin 3, which shuts down thrombin, IIA, and ZAR. DOACs, direct oral anticoagulants. Factor ZAR inhibitors, Zarban drugs, apixaban, rivaroxaban. Direct thrombin inhibitors, dabigatran. Figure, extra detailed AI-ready prompt for AI-generated diagram of the coagulation cascade. Modern, 3D medical illustration style. Show the intrinsic and extrinsic pathways merging into the common pathway. Highlight factor ZAR with a neon glow, showing apixaban rivaroxaban blocking it. Highlight thrombin, factor IIA, with a glow, showing dabigatran blocking it. Include a visual cue for warfarin affecting the production side, liver. Background should be dark to make the pathway pop. Managing bleeding risks. For the PEBC, you must know what to do when things go wrong. If a patient on anticoagulants presents with a bleed or requires emergency surgery, you are the drug expert the team relies on. Anticoagulant reversal agent. Antiplatelet dual therapy, DAPT. Following an acute coronary syndrome, ACS, or stent placement, we use DAPT, aspirin plus AP2Y12 inhibitor, clopidogrel, ticagrelor, or prasugrel. Ticagrelor, reversible binding, twice daily. Watch for dyspnea. Prasugrel, high potency. Contraindicated in history of stroke TIA or age greater than 75, bleed risk outweighs benefit. Clopidogrel, needs CYP2C19 bioactivation. Less effective in genetic poor metabolizers. This chapter has provided the clinical logic for the most common prescriptions you will verify. In the next chapter, we will tackle the endocrine system, specifically the nuanced management of diabetes mellitus, where lifestyle and pharmacology intersect dramatically. Chapter 4, Endocrinology and Metabolic Disorders. Sections, Section 4.1, Diabetes mellitus Part 1, Insulin pharmacotherapy and injection technique, Section 4.2, Diabetes mellitus Part 2, Oral agents and cardiovascular protection, Section 4.3, Thyroid disorders. Interpretation of TSH and T4 monitoring, Section 4.4, Women's Health, Contraception Selection and Menopause Management, Section 4.5, Osteoporosis Strategies, Calcium, Vitamin D, and Bisphosphonates. In Chapter 3, we navigated the mechanical engine room of the body, the cardiovascular and respiratory systems that keep blood flowing and oxygen cycling. Now, we turn our attention to the body's software, the endocrine system. If the heart is the pump, hormones are the Wi-Fi signals sending critical instructions to every cell. When these signals drop or get crossed, the metabolic consequences are systemic and often silent until damage occurs. For the PEBC, this chapter is pivotal because endocrine disorders, specifically diabetes and thyroid issues, are among the most common conditions you will manage in community pharmacy. This is not just about memorizing negative feedback loops. It is about interpreting lab values to adjust life-sustaining medication and counseling patients through lifestyle changes that feel overwhelming to them. We will break this complex network down into actionable clinical strategies, focusing on the rigorous guidelines defined by Diabetes Canada and other national bodies. Let's synchronize the system. 4.1 Diabetes mellitus Part 1, Insulin Pharmacotherapy and Injection Technique. Diabetes is the ultimate test of a pharmacist's ability to blend pharmacology with empathy. You are asking patients to inject a substance daily, monitor their blood sugar, and overhaul their diet. Your role is to simplify this burden. We begin with insulin. In the PEBC exams, you must distinguish between basal, background, and bolus, mealtime, insulin, and know exactly how to fix a regimen when the numbers go wrong. The basal bolus concept. Think of endogenous insulin production like the electricity in your home. There is always a low level of power running the refrigerator and clocks, basal, and then there are spikes in usage when you turn on the dryer or oven, bolus. Type 1 diabetics have lost the generator, they need full replacement. Type 2 diabetics usually have a struggling generator, they might need a boost. Basal insulins, the background, these keep glucose stable overnight and between meals. Asterisk intermediate, NPH, the old standard. Looks cloudy. Peaks at 4 to 10 hours, risk of nocturnal hypoglycemia. Asterisk long-acting, Glargine U100, Detemir, the workhorses. No distinct peak. Lasts tilde 24 hours. Asterisk ultra-long-acting, Glargine U300, Degludec, the new guard. Lasts greater than 24 hours with less variability and lower hypoglycemia risk. Bolus insulins, the mealtime response, these handle the carbohydrate spike. Asterisk rapid-acting, Aspart, Lispro, Glulicine, shoot and eat. Onset in 10 to 15 minutes. Asterisk short-acting, regular, the older version. Take 30 minutes before eating. Figure, a clean, color-coded timeline graph comparing insulin pharmacokinetics. The x-axis represents time, 0 to 24 hours, and the y-axis represents insulin effect. Show 4 distinct curves: rapid-acting, sharp peak at 1 hour, gone by 4, short-acting, slower peak, gone by the 6th of August, NPH, hump at 6 to 8 hours, gone by the 16th of December, and long-acting, flat line, steady for 24 hours. The style should be modern vector art suitable for a medical textbook, white background, distinct primary colors for lines. Interpreting patterns for dose adjustments. Here is the golden rule for the exam: fix the problem where it starts. If the fasting morning glucose is high, the overnight coverage failed. You adjust the basal. If the post-lunch glucose is high, the breakfast bolus was insufficient, or the lunch bolus needs to be higher depending on when you measure. Somogyi effect, rebound hyperglycemia. The patient goes low at 3 a.m., hypo, and the body panics, dumping glucagon epinephrine, causing a high at 7 a.m. Solution: lower the bedtime dose or add a snack. Dawn phenomenon, natural morning rise in hormones, growth hormone cortisol, causing high morning sugar. Solution: increase the basal dose. Injection technique and site rotation. For an OSCE station, technical knowledge isn't enough, you need to demonstrate technique. If a patient's sugars are erratic despite good compliance, check their abdomen. Lipohypertrophy, fatty lumps caused by repeated injections in the same spot, prevents insulin absorption. Counseling checklist. 1. Site selection, abdomen, fastest, arm, thigh, buttock. 2. Rotation, imagine a clock face on the abdomen, move to a new hour every week. 3. Needle, use a fresh needle every time. Reusing dulls the tip and increases pain. 4. Storage, open pens stay at room temperature, usually for 28 to 30 days, unopened stock stays in the fridge. 4.2 Diabetes mellitus Part 2, oral agents and cardiovascular protection. In the past decade, diabetes management has undergone a paradigm shift. We no longer just treat the A1C, the number, we treat the risk. The PEBC loves to test this nuance. If a patient has type 2 diabetes, T2DM, and a history of heart attack, metformin alone is not the best answer anymore. You must add cardioprotective agents. The big three classes. While there are many drug classes, sulfonylureas, DPP-4 inhibitors, TZDs, 3 dominate the modern guidelines. Drug class key mechanism, the superpower key side effects. The guideline algorithm. When you see a case study, ask these questions in order. Is the A1C greater than 1.5% above target? If yes, start metformin plus a second agent immediately. Does the patient have ASCVD, atherosclerotic cardiovascular disease? E.g., prior MI, stroke. Action: add GLP-1 or SGLT2 with proven benefit. Does the patient have heart failure, HFrEF, or CKD? Action: SGLT2 inhibitors are preferred. Sick day management, SADMANS. This is a critical safety counseling point. When a diabetic patient gets sick, dehydrated, flu, gastro, certain meds can damage the kidneys or cause acidosis. They must pause these meds. Sulfonylureas A, ACE inhibitors D, diuretics direct renin inhibitors M, metformin A, ARBs N, NSAIDs S, SGLT2 inhibitors. Instruct the patient to hold these until they are eating and drinking normally again. 4.3 Thyroid disorders, interpretation of TSH and T4 monitoring. The thyroid is the thermostat of the body's metabolism. For the exam, you need to master the seesaw relationship between TSH, thyroid stimulating hormone, and T4, thyroxine. The feedback loop, the seesaw. The pituitary gland sends TSH to yell at the thyroid to work. Hyperthyroidism, the thyroid is asleep, low T4. The pituitary screams louder to wake it up, high TSH. Hyperthyroidism, the thyroid is partying too hard, high T4. The pituitary whispers or shuts up, low TSH. Figure: a schematic diagram illustrating the hypothalamus-pituitary-thyroid axis negative feedback loop. Top box, hypothalamus, TRH. Middle box, pituitary, TSH. Bottom box, thyroid gland, T3, T4. Arrows show stimulation going down, and red dashed lines show inhibition, negative feedback, going back up from T3, T4 to the pituitary and hypothalamus. Clear labels, educational style. Levothyroxine management. Levothyroxine, T4, is the gold standard for hyperthyroidism. It has a narrow therapeutic index, meaning small changes matter. Dosing, *1.6 micrograms per kilogram per day is the standard full replacement dose. Start low, 12.5 to 25 micrograms, in the elderly or those with cardiac history, going too fast can trigger angina. Administration rules, take on an empty stomach, 30 to 60 minutes before breakfast. The chelation interaction, separate from calcium, iron, antacids, and multivitamins by 4 hours. This is a classic exam interaction that causes treatment failure. Monitoring, TSH takes about 6 to 8 weeks to stabilize. Do not adjust doses every 2 weeks, you will end up chasing your tail. Pregnancy, requirements increase by 30 to 50% immediately. This is vital for fetal brain development. 4.4 Women's health, contraception selection and menopause management. This section requires a delicate balance of guideline knowledge and patient-specific factors. There is no one-size-fits-all. Contraception, selecting the CHC. Combined hormonal contraceptives, CHC, contain estrogen and progestin. Estrogen stabilizes the lining and prevents ovulation. Progestin provides the primary contraceptive effect, thickens mucus. The aches of estrogen. Estrogen increases clotting risk. You must screen for VTE, venous thromboembolism, history and migraine with aura, stroke risk. Teach patients the warning signs, abdominal pain, severe, chest pain, PE, MI, headaches, severe, eye problems, vision loss, severe leg pain, DVT. Managing side effects, breakthrough bleeding, early cycle need more estrogen. Breakthrough bleeding, late cycle need more progestin. Acne hirsutism, choose a less androgenic progestin, e.g., drospirenone, norgestimate. Mist pills, the rules vary by product, but generally, *1 pill mist, take ASAP, continue normal schedule, even if 2 in one day. No backup needed. *2+ pills mist, take 1 ASAP, discard other mist pills. Backup contraception needed for 7 days. If in week 3, skip the placebo week and start a new pack. Menopause management. Menopause is not a disease, it is a transition. We treat the symptoms, vasomotor symptoms (VMS), if they impact quality of life. Hormone replacement therapy, HRT** uterus intact, must use estrogen plus progesterone. Unopposed estrogen causes endometrial hyperplasia cancer. Hysterectomy, can use estrogen alone. The risk-benefit conversation. Current evidence suggests HRT is safe for healthy women less than 60 years old or within 10 years of menopause onset. The risk of breast cancer increases slightly with long-term use, greater than 5 years, of combined therapy. 4.5 Osteoporosis strategies, calcium, vitamin D, and bisphosphonates. Osteoporosis is the silent thief. It steals bone mass without symptoms until a fracture occurs. Your goal is fracture prevention. The foundation, calcium and vitamin D. Supplements are the baseline, but diet is preferred. Calcium carbonate requires acid for absorption. Take with food. Poor choice for patients on PPIs like pantoprazole. Calcium citrate, acid independent. Can take on an empty stomach. Good for elderly PPI users. Dose, aim for 1,200 mg elemental calcium daily, diet plus sups combined. Do not exceed 500 mg per dose, absorption limit. Bisphosphonates, alendronate, risedronate. These drugs inhibit osteoclasts, the bone eaters. They are highly effective but have strict administration rules due to esophagitis risk. Counseling points, OSCE Gold 1. Take first thing in the morning. 2. Take with a full glass of plain water only. 3. Stay upright, do not lie down, for 30 minutes. 4. Wait 30 minutes before eating, drinking other fluids, or taking other meds. Rare but serious adverse effects, osteonecrosis of the jaw, ONJ rare. Associated with high-dose use or dental surgery. Atypical femur fracture, associated with long-term use, greater than 5 years. This is why we consider a drug holiday after 3 to 5 years of stability. We pause the drug, as the bone retains the medication, maintaining protection while reducing side effect risks. Summary. Endocrinology is about balance. In diabetes, you balance glucose against hypoglycemia. In thyroid disorders, you balance TSH against T4. In women's health and osteoporosis, you balance symptom relief against long-term risks. When answering exam questions, always look at the whole patient. A correct drug choice that ignores a patient's kidney function or ability to swallow is a wrong answer. In the next chapter, we will tackle the complexities of neurology and psychiatry, where the monitoring parameters become less numerical and more behavioral. Chapter 5, Neurology, Psychiatry, and Pain Management. Section 5.1, Depression and Anxiety, Selecting first-line agents and managing washout periods. Section 5.2, the pain ladder, assessment, NSAIDs, and responsible opioid stewardship. Section 5.3, seizure disorders, anticonvulsant mechanics and therapeutic drug monitoring. Section 5.4, insomnia and sleep hygiene, pharmacological versus non-pharmacological approaches. Section 5.5, neurodegenerative conditions, Parkinson's and Alzheimer's therapeutics. In Chapter 4, we examined the body's hormonal software, the endocrine system that regulates metabolism silently in the background. Now, we shift our focus to the user interface of human existence, the nervous system. This is where biology meets biography. Neurology and psychiatry represent the most subjective challenges you will face as a pharmacist. Unlike hypertension, where a blood pressure cuff gives you a clear number, pain and depression rely on the patient's narrative. Your role changes here. You are no longer just a scientist interpreting data, but a translator of suffering into therapeutic action. For the PEBC, this section is notoriously difficult because of the nuances. Drug interactions here are not just theoretical, they can be fatal. Think serotonin syndrome. The therapeutic windows are narrow, and the side effects affect daily functioning. We will tackle these complex networks with a focus on safety, efficacy, and empathy. 5.1 Depression and anxiety, selecting first-line agents and managing washout periods. Depression and anxiety are no longer viewed merely as chemical imbalances, but as complex dysregulations of neural circuitry. As a pharmacist, your primary goal is to facilitate remission while minimizing the initial side effects that often cause patients to quit therapy early. Selecting the right agent. In Canada, guidelines generally favor SSRIs, selective serotonin reuptake inhibitors, and SNRIs, serotonin norepinephrine reuptake inhibitors, as first-line treatments. However, first-line does not mean one size fits all. You must match the drug's profile to the patient's specific symptoms and comorbidities. If a patient presents with depression accompanied by fatigue and neuropathic pain, an SNRI like duloxetine may be preferable due to its norepinephrine activity. Conversely, for a patient with significant insomnia and weight loss, mirtazapine might be chosen for its sedating and appetite-stimulating properties. Figure, detailed technical diagram comparing the mechanism of action of SSRIs, SNRIs, and TCAs at the synaptic cleft. The visual should highlight the reuptake pumps for serotonin, 5-HT, and norepinephrine, NE, showing blocking actions. Include distinct icons for neurotransmitters. The style should be clean, medical vector art with a white background. The washout period, a critical safety check. One of the most high-yield PEBC concepts in psychiatry is the washout period. Switching antidepressants is common, but doing it incorrectly can trigger serotonin syndrome, a potentially life-threatening condition characterized by hypothermia, agitation, and clonus. You must be vigilant when switching between agents that impact serotonin, particularly monoamine oxidase inhibitors, MAOIs. The body needs time to regenerate the MAO enzyme before introducing a serotonergic agent. Switching to required washout period. Note, fluoxetine is the trap question. Its active metabolite, norfluoxetine, has a massive half-life. If a case scenario involves switching from Prozac, fluoxetine, pause and check the timeline immediately. 5.2 The pain ladder, assessment, NSAIDs, and responsible opioid stewardship. Pain management is a balancing act between compassionate relief and the prevention of harm. In Canada, the opioid crisis has fundamentally shifted how we approach pain. The PEBC expects you to be a steward, not just a dispenser. Assessment, the fifth vital sign. Before recommending a drug, you must assess the pain. Use the PQRST mnemonic: provokes, quality, radiates, severity, time. Is the pain nociceptive, tissue damage, or neuropathic, nerve damage? Nociceptive pain usually responds to NSAIDs and opioids. Neuropathic pain, burning, shooting, often requires adjuvants like gabapentin, pregabalin, or TCAs. Recognizing this distinction is key to solving case-based questions on the exam. The WHO Pain Ladder and NSAIDs. The World Health Organization, WHO, ladder suggests starting with non-opioids. Acetaminophen and NSAIDs are the foundation. However, NSAIDs are not benign. Recall your renal physiology from Chapter 2. NSAIDs constrict the afferent arteriole, reducing glomerular filtration. In elderly patients or those on ACE inhibitors ARBs, which dilate the efferent arteriole, adding NSAID can precipitate acute kidney injury. This triple whammy is a classic exam scenario. Opioid stewardship. When moving up the ladder to opioids, the mantra is start low, go slow. For the PEBC, you must demonstrate knowledge of opioid rotation and morphine equivalent doses, MED. If a patient is rotated from oral morphine to hydromorphone, you generally calculate the equianalgesic dose and then reduce it by 25 to 50% to account for incomplete cross-tolerance. Failure to reduce the dose is a critical safety error. Figure: a structured flowchart illustrating the opioid rotation calculation process. Step 1. Calculate total daily dose of current opioid. Step 2. Convert to morphine equivalents, MEQ, using a conversion table. Step 3. Convert MEQ to new opioid dose. Step 4. Apply safety reduction, 25 to 50%. Step 5. Determine breakthrough dosing, 10 to 15% of total daily dose. The design should be a practical decision tree used in clinical settings. 5.3 Seizure disorders, anticonvulsant mechanics and therapeutic drug monitoring. Epilepsy management relies heavily on pharmacokinetics. Many anticonvulsants are narrow therapeutic index, NTI, drugs. Small changes in dose or interactions can lead to breakthrough seizures or toxicity. Mechanisms of action. Most anticonvulsants work by stabilizing the neuronal membrane. They do this by blocking sodium, Na+, channels, e.g., phenytoin, carbamazepine, calcium, Ca2+, channels, e.g., ethosuximide, or enhancing GABA activity, e.g., benzodiazepines, phenobarbital. Understanding the mechanism helps you predict side effects. Na+ channel blockers often cause CNS slowing and cardiac conduction issues. GABA enhancers are sedating. Therapeutic drug monitoring, TDM. Phenytoin is the king of PEBC pharmacokinetic questions. It exhibits Michaelis-Menten kinetics, saturable metabolism. At low concentrations, it follows first-order kinetics, linear. Once the enzymes are saturated, it shifts to zero-order kinetics. This means a small increase in dose can result in a disproportionately large spike in serum concentration, leading to toxicity, nystagmus, ataxia. Also, be aware of carbamazepine, which induces its own metabolism, autoinduction. A dose that is therapeutic in week 1 may become subtherapeutic by week 4 as the liver ramps up enzyme production. 5.4 Insomnia and sleep hygiene, pharmacological versus non-pharmacological approaches. In our fast-paced society, patients frequently seek chemical solutions for sleep. The PEBC emphasizes a skills before pills approach. Your first recommendation must always be cognitive behavioral therapy for insomnia, CBTI, and sleep hygiene. Sleep hygiene first. Before reaching for a prescription, assess the patient's habits. Are they consuming caffeine late in the day? Are they using blue light screens in bed? Is the bedroom environment conducive to rest? Correcting these behaviors is the only long-term cure for primary insomnia. Pharmacotherapy is intended for short-term distress or transient insomnia. Pharmacological management. When drugs are necessary, selection depends on the type of insomnia, sleep onset versus sleep maintenance. Z-drugs, zopiclone, zolpidem bind to the benzodiazepine site on GABA receptors. Effective for onset, but carry risks of complex sleep behaviors, sleep-driving eating. Benzodiazepines, temazepam, lorazepam effective, but alter sleep architecture, reduce deep sleep, and carry high abuse potential. Ortion antagonists, lemborexant, a newer class that blocks the wakefulness signal rather than inducing sedation. Caution: in elderly patients, 65+, Z drugs and benzodiazepines are on the Beers criteria list due to fall risk and cognitive decline. Avoid them whenever possible. 5.5 Neurodegenerative conditions, Parkinson's and Alzheimer's therapeutics. Neurodegenerative diseases are heartbreaking for families and complex for pharmacists. We cannot yet cure these conditions, we can only manage symptoms to preserve quality of life. Parkinson's disease, the dopamine drought. Parkinson's is primarily a loss of dopaminergic neurons in the substantia nigra. The hallmark symptoms are tremor, resting, rigidity, akinesia, bradykinesia, and postural instability. Our goal is to restore dopamine. Levodopa-carbidopa is the gold standard. Levodopa crosses the blood-brain barrier, BBB, and converts to dopamine. Carbidopa prevents peripheral conversion to reduce side effects like nausea. Clinical Pearl: over time, patients develop the wearing-off phenomenon. You may need to add a COMT inhibitor, entacapone, or an MAOB inhibitor, razugeline, to extend the duration of levodopa's effect. Alzheimer's disease, cholinergic deficit. In Alzheimer's, we see a deficiency in acetylcholine, ACH, which is vital for memory. We treat this with acetylcholinesterase inhibitors, donepal, rivastigmine, galantamine. These drugs inhibit the enzyme that breaks down ACH, effectively increasing its concentration in the synapse. Side effects are sludge, cholinergic excess salivation, lacrimation, urination, diarrhea, GI upset, emesis. Warn caregivers about GI upset, as it is the most common reason for discontinuation. Figure: a comparative illustration showing a healthy neuron versus an Alzheimer's neuron and a Parkinson's neuron. The Parkinson's section should zoom in on the substantia nigra showing low dopamine. The Alzheimer's section should show amyloid plaques and low acetylcholine. Use simplified icons to represent the neurotransmitter levels, droplets. Lighting should be soft, highlighting the areas of deficit. Summary: we have navigated the complex circuitry of the nervous system. From balancing neurotransmitters in depression to managing the delicate kinetics of anticonvulsants, this chapter required you to think about the person behind the pathology. Remember, in neurology and psychiatry, the difference between a therapeutic outcome and a toxic event is often a matter of careful monitoring and patient education. You are the safety net. In the next chapter, we will shift gears entirely to tackle the invaders, infectious diseases and immunology. We will move from internal regulation to external defense, exploring how to select the right antimicrobial for the right bug.
Chapter 6: Infectious Diseases and Immunology. Sections: Section 6.1 Community-acquired infections, respiratory, urinary, and skin considerations. Section 6.2 Antibiotic stewardship, spectrum of activity and adverse effect profiles. Section 6.3 The Canadian Immunization Guide, schedules, cold chain, and administration. Section 6.4 Viral concerns, HIV basics, hepatitis C therapies, and prophylaxis. Section 6.5 Travel medicine, malaria prophylaxis and traveler's diarrhea. In Chapter 5, we navigated the subjective, grey waters of neurology and psychiatry, where patient narrative often dictates therapy. Now, we shift gears entirely. We are entering a battlefield where the enemy is distinct, microscopic, and rapidly evolving. Infectious disease, ID, is biological warfare, and as a pharmacist, you are the quartermaster supplying the ammunition. For the PEBC, this chapter is unique because it demands a rigorous adherence to guidelines. Unlike pain management, where trial and error is acceptable, infectious disease requires precision. Using the wrong antibiotic does not just fail the patient, it breeds resistance that threatens the entire community. This section requires you to balance three competing interests: the patient, efficacy, safety; the pathogen, susceptibility; and the population, stewardship. We will move beyond rote memorization of bug-drug pairs and focus on the clinical decision-making trees used in Canadian practice. Let's equip you to fight the invisible war. 6.1 Community-acquired infections, respiratory, urinary, and skin considerations. The vast majority of your day-to-day practice in community pharmacy involves these three systems. The PEBC loves these topics because they test your ability to differentiate between viral conditions, which need supportive care, and bacterial infections, which need antibiotics. Respiratory tract infections. Upper respiratory tract infections are the primary driver of unnecessary antibiotic prescribing. Your role here is largely gatekeeping. You must confidently distinguish between acute otitis media, AOM, bacterial sinusitis, and the common cold. For AOM in children, the watchful waiting period is a critical Canadian guideline nuance. We do not immediately blast a 4-year-old with amoxicillin if they are afebrile and the pain is manageable. However, if symptoms persist beyond 48 hours, high-dose amoxicillin is our standard soldier to overcome resistant S. pneumoniae. Community-acquired pneumonia, CAP, requires a risk stratification approach. Is the patient healthy, or do they have comorbidities? For a healthy outpatient, amoxicillin or doxycycline usually suffices. If they have chronic heart or lung disease, we escalate to a fluoroquinolone or a beta-lactam plus a macrolide to cover atypical pathogens like Legionella or Mycoplasma. Urinary tract infections, UTIs. Figure A detailed, high-contrast decision tree flowchart on a white background. The chart starts at the top with patient presents with respiratory symptoms. Branch is split into the upper respiratory and lower respiratory. The upper branch splits into viral, supportive care, and bacterial suspicion. Visual icons represent the ear, AOM, sinuses, and lungs. Color-coded pathways, green for virals wait, red for treat, lead to text boxes containing Canadian guideline first-line therapies like amoxicillin and azithromycin. The style is clean, modern medical vector art. In the OSCE, you will frequently encounter the UTI consult. The first question you must answer is this uncomplicated or complicated? An uncomplicated UTI occurs in a healthy, non-pregnant, premenopausal female with normal anatomy. For uncomplicated cystitis, nitrofurantoin or fosfomycin are the preferred snipers. They concentrate in the bladder with minimal systemic collateral damage. Avoid fluoroquinolones here. Using Cipro for a simple UTI is like using a bazooka to kill a mosquito, effective, but reckless regarding resistance. If the infection ascends to the kidneys, pyelonephritis, indicated by flank pain and fever, the rules change. We need systemic tissue penetration. Here, fluoroquinolones or TMP, SMX, Septra, become necessary because nitrofurantoin simply cannot reach the renal tissue levels required to clear the infection. Skin and soft tissue infections. Skin infections range from non-purulent cellulitis to purulent abscesses. The dividing line is the presence of pus, which typically signals Staphylococcus aureus, potentially MRSA. For non-purulent cellulitis, often streptococcal, cephalexin or penicillin VK remains effective. However, if you see an abscess or purulent drainage in a case study, your radar for methicillin-resistant Staphylococcus aureus, CAMRSA, must activate. In these cases, incision and drainage are primary, often supplemented by doxycycline or TMP-SMX. 6.2 Antibiotic stewardship, spectrum of activity and adverse effect profiles. Antibiotic stewardship is not just a buzzword, it is a competency tested on the PEBC. You will be evaluated on your ability to de-escalate therapy. This means narrowing the spectrum of coverage once a pathogen is identified or when empirical broad coverage is no longer justified. The spectrum of activity. Think of antibiotics as having a blast radius. Broad-spectrum agents like meropenem or piperacillin-tazobactam have a massive radius, killing gut flora and increasing the risk of Clostridioides difficile. Narrow-spectrum agents like penicillin are precision strikes. Your goal is always to use the narrowest effective agent. For example, if a culture comes back sensitive to both ceftriaxone and ampicillin, the correct answer is to switch to ampicillin. This preserves the big guns for when we truly need them. Adverse effect profiles. You must memorize the personality of each antibiotic class. They all have distinct red flags that will appear in MCQs as contraindications or counseling points. Antibiotic class key adverse effects clinical pearl for PEBC. Figure, a pharmacological infographic showing a human silhouette. Call-out bubbles point to specific organs illustrating antibiotic side effects. An ear icon for aminoglycosides, ototoxicity, a heel tendon icon for fluoroquinolinase, rupture, a heart icon with an ECG line for macrolides, QT prolongation, and a kidney icon for vancomycin. The design uses a sterile blue and white palette with red warning icons. 6.3 The Canadian Immunization Guide, Schedules, Cold Chain, and Administration. Canada takes immunization seriously. The Canadian Immunization Guide is your Bible here. You will encounter questions involving catch-up schedules for immigrants and the management of vaccine logistics. The cold chain. Vaccines are biological products, they are fragile. The cold chain refers to the temperature-controlled supply chain, usually plus 2 degrees Celsius to plus 8 degrees Celsius. A breach occurs when temperatures deviate. If you encounter a scenario where the fridge was left open, the correct answer is almost never discard everything immediately or use them anyway. The correct action is to quarantine the stock, mark Do Not Use, and contact the public health unit or manufacturer for stability data. This demonstrates professional responsibility and resource management. Administration and schedules. You must be comfortable with the injection sites. For infants under 12 months, the vastus lateralis, thigh, is the only safe site. The deltoid is reserved for those older than 12 months who have sufficient muscle mass. Regarding schedules, focus on live versus inactivated vaccines. Live vaccines, MMR, varicella, generally cannot be given to immunocompromised patients or pregnant women. Furthermore, if 2 live parenteral vaccines are not given on the same day, they must be separated by at least 4 weeks to prevent immune interference. 6. For viral concerns, HIV basics, hepatitis C, and prophylaxis. Viral management has transformed from palliative care to chronic disease management and curative therapy. Your role has shifted from managing death to managing lifelong adherence and drug interactions. HIV, undetectable equals untransmittable. The modern mantra of HIV care is U equals U. If a patient maintains an undetectable viral load, they cannot transmit the virus. This is a vital counseling point to reduce stigma and encourage adherence. Therapy generally consists of a backbone of 2 NRTIs, nucleoside reverse transcriptase inhibitors, plus a third agent, usually an integrase inhibitor, INSTI. For the PEBC, watch out for drug interactions. Boosters like ritonavir or cobicistat are potent CYP inhibitors. If a patient on HIV med starts a statin or a fluticasone inhaler, alarm bells should ring. Hepatitis C, the curative era. Hepatitis C treatment has revolutionized with direct-acting antivirals, DAAs. We cure this disease now. The challenge is no longer side effects, as it was with interferon, but rather genotype matching and drug interactions. You must screen for hepatitis B before starting DAAs. Treating Hep C can remove the immune pressure on a dormant Hep B co-infection, causing a potentially fatal Hep B reactivation. Pre- and post-exposure prophylaxis. PrEP, pre-exposure prophylaxis, involves taking Truvada, or Descovy, daily to prevent HIV acquisition. It requires regular HIV testing and renal monitoring. PEP, post-exposure prophylaxis, is an emergency. It must be started within 72 hours of exposure, sexual or occupational, and continued for 28 days. In an OSCE, if a patient comes in 4 days after a high-risk event, you must break the hard news: PEP is no longer effective, and testing is the only path forward. 6.5 Travel medicine, malaria and traveler's diarrhea. As a pharmacist, you are often the last healthcare provider a traveler sees before departure. This is a high liability area because giving the wrong advice can leave a patient unprotected in a high-risk zone. Malaria prophylaxis. There is no one-size-fits-all pill. The choice depends on the destination, resistance patterns, and the patient profile. Chloroquine, largely obsolete for P. falciparum in most of the world due to resistance, but safe for pregnancy. Atovaquone Progonal, Malarone great for short trips. Started 1 day before and continued only 7 days after. Expensive but well tolerated. Doxycycline, cheap and effective. Good for long trips, but causes sun sensitivity. Mefloquine, effective, but carries a black box warning for neuropsychiatric effects. Do not give this to a patient with a history of depression or anxiety, recall Chapter 5. Traveler's diarrhea. The primary intervention is always hydration, oral rehydration salts. Antibiotics are reserved for moderate to severe cases. Ciprofloxacin was the old standard, but resistance in Southeast Asia, Campylobacter, is high. Azithromycin is now the preferred agent for dysentery, bloody diarrhea, or travel to Southeast Asia. Rifaximin is an option for non-invasive strains but is useless for invasive infections. Figure, a split-screen illustration contrasting two travel scenarios. On the left, a safari scene with a mosquito icon and a bottle of Atovaquone Progonal. On the right, a beach resort scene focusing on food safety, boil it, cook it, peel it, or forget it, and a pack of oral rehydration salts. The style is instructional and semi-realistic, highlighting the items clearly. Conclusion. Infectious disease pharmacy is a discipline of rules, exceptions, and responsibility. You are protecting your patient from the pathogen, but you are also protecting the community from the patient's potential resistance. When you study this chapter, do not just memorize the drug names. Ask yourself why. Why is nitrofurantoin okay for the bladder but not the kidney? Why do we separate live vaccines? Why is hydration more important than antibiotics in diarrhea? Once you understand the why, the what becomes intuitive. In the next chapter, we will tackle the complex world of oncology and hematology, where the drugs we use are toxic by design, and the therapeutic window is razor thin.
Chapter 7. Gastrointestinal, renal, and special populations. Sections, Section 7.1, Upper GI disorders, GERD, peptic ulcers, and H. pylori eradication, Section 7.2, Pediatric pharmacotherapy, weight-based dosing and formulation challenges, Section 7.3, Geriatric pearls, the Beers criteria and preventing falls, Section 7.4, Pregnancy and lactation, assessing risk using Briggs and MotherRisk data, Section 7.5, Renal and hepatic impairment, dose adjustments and contraindications. In Chapter 6, we operated as quartermasters on the infectious disease battlefield, deploying precise weaponry against distinct microbial enemies. Now, we must shift our mindset from warfare to customization. We are moving into the delicate infrastructure of the body, the plumbing and filtration systems, and the diverse demographics that rely on them. Standard dosing is a myth. The average 70 kilograms male referenced in textbooks rarely walks into your pharmacy. Instead, you will see a premature infant requiring micrograms of digoxin, a pregnant patient terrified to take acetaminophen, or an elderly patient whose kidneys can no longer handle the metformin they have taken for decades. For the PEBC, this chapter tests your adaptability. You cannot memorize a single dose and apply it universally. You must evaluate the host before you evaluate the drug. This section requires you to act as a safety filter, catching the errors that occur when standard protocols meet non-standard physiology. 7.1 Upper GI disorders, GERD, peptic ulcers, and H. pylori eradication. The upper gastrointestinal tract is the gateway for oral pharmacotherapy, but it is also a hostile environment. Management of upper GI disorders is about balancing aggressive factors, acid, pepsin, with defensive mechanisms, mucus, bicarbonate. When this balance tips, you encounter everything from mild heartburn to life-threatening perforations. GERD and step-up versus step-down therapy. Gastroesophageal reflux disease, GERD, is one of the most common complaints you will face in community practice. The PEBC expects you to differentiate between functional heartburn and alarm symptoms that require immediate referral. Dysphagia, odonophagia, unexplained weight loss, and anemia are your red flags. Do not treat these with OTC antacids. Therapeutic selection often involves a step-down approach for severe erosive esophagitis, starting with high-dose PPIs, or a step-up approach for mild symptoms, lifestyle changes, and H2-RAS. Your counseling here is critical. Proton pump inhibitors, PPIs, are not rescue medications. They require consistent dosing, ideally 30 to 60 minutes before the first meal, to inhibit active proton pumps effectively. Figure: a split-screen diagram comparing a healthy lower esophageal sphincter, LES, versus a relaxed LES in a GERD patient. The left side shows a tight seal preventing green gastric acid from rising. The right side shows a gap with acid refluxing into the esophagus. Callouts highlight alarm symptoms, dysphagia, bleeding, pointing to a refer to physician icon, while mild symptoms point to a pharmacist intervention path involving lifestyle changes and alginates. Peptic ulcer disease, PUD, and said risks. Peptic ulcers are essentially chemical burns in the stomach or duodenum. A major culprit in modern pharmacy is the chronic use of NSAIDs, which inhibit COX-1-mediated prostaglandin synthesis, the stomach's natural armor. In the OSCE, you may encounter a patient requesting ibuprofen who has a history of PUD. Your job is to identify the contraindication and recommend alternatives like acetaminophen or a COX-2 selective inhibitor with a PPI. H. Pylori eradication strategies. When PUD is caused by Helicobacter pylori, acid suppression alone is insufficient. You must eradicate the infection. The guidelines here are evolving due to rising clarithromycin resistance. The triple therapy, PPI plus clarithromycin plus amoxicillin metronidazole, is failing in many regions, making quadruple therapy the new standard for many populations. Regimen type components. Duration. Clinical note. Success depends on adherence. Counseling a patient to take 4 different medications multiple times a day for 2 weeks is a communication challenge. Emphasize that missing doses allows the bacteria to survive and develop further resistance. 7.2 Pediatric pharmacotherapy, weight-based dosing and formulation challenges. Children are not merely small adults. Their metabolic pathways are immature, their body water composition is higher, and their blood-brain barrier is more permeable. In pediatrics, a calculation error isn't just a mistake, it can be a tragedy. The math of safety. Always dose by weight, milligram-kilogram, rather than age, unless the child exceeds the adult weight, roughly 40 to 50 kilograms, at which point adult dosing usually caps the calculation. You must be vigilant with units. Converting pounds to kilograms is the first step of every pediatric interaction. Watch for the gray zone in dosing. For example, in amoxicillin dosing for otitis media, the high-dose strategy, 80 to 90 mg/kg day, is required to overcome resistant S. pneumoniae. Underdosing leads to treatment failure, while overdosing increases GI side effects. Figure: a visual infographic of a pediatric dosing workflow. Step 1 shows a scale converting pounds to kilogram. Step 2 shows a calculator verifying milligram-kilogram against a reference range. Step 3 shows a liquid oral syringe with a clear meniscus line. Warning icons appear near kitchen spoons indicating they are inaccurate for measurement. Formulation and compliance. The best drug in the world is useless if the child spits it out. Taste, texture, and volume are pharmacokinetic variables in pediatrics. If a medication requires compounding, ensure the vehicle is appropriate, e.g., alcohol-free. Furthermore, never assume a parent knows how to measure liquids. 1 teaspoon from the silverware drawer can range from 2 milliliters to 7 milliliters. In an OSCE station, always hand the patient an oral syringe and demonstrate how to measure the dose at eye level. This tactile demonstration is often a checklist item. 7.3 Geriatric pearls, the Beers criteria and preventing falls. As physiology ages, homeostatic reserves deplete. This leads to the prescribing cascade, where a side effect of one drug is misinterpreted as a new medical condition, leading to the prescription of a second drug. Your role is to be the deprescribing advocate. The Beers criteria. The Beers criteria is your primary reference for potentially inappropriate medications, PIMS, in older adults. It flags drugs where the risk likely outweighs the benefit. The most common offenders in community pharmacy are anticholinergics, like diphenhydramine, benzodiazepines, and sliding scale insulin. Anticholinergic burden is particularly dangerous. It causes confusion, constipation, urinary retention, and blurred vision, often mimicking dementia. Before a patient is started on a cognitive enhancer like Donepal, check if they are taking medications that cause the confusion in the first place. Falls and orthostasis. Falls are a leading cause of morbidity in the elderly. Pharmacists must screen for drugs that cause orthostatic hypertension, alpha blockers, diuretics, or sedation, sedative hypnotics, opioids. If an elderly patient presents with a new complaint of dizziness, check their blood pressure medications. Are they on a diuretic and an ACE inhibitor while dehydrated? Adjusting the timing of administration or reducing the dose can preserve their independence and prevent a hip fracture. 7.4 Pregnancy and lactation, assessing risk using Briggs and MotherRisk data. Treating a pregnant or lactating patient involves managing two patients simultaneously. This leads to high anxiety for both the mother and the pharmacist. Historically, we relied on the FDA's ABCDX letter categories, but these were overly simplistic and have been largely phased out in favor of descriptive risk analysis. Navigating risk data. You must rely on specialized resources like Drugs in Pregnancy and Lactation, Briggs, or legacy data principles from MotherRisk, and current equivalents. The goal is to interpret the data. Does the drug cross the placenta? Is it teratogenic in the first trimester, organogenesis, or toxic in the third, fetal adaptation? For example, ACE inhibitors are contraindicated in the second and third trimesters due to renal toxicity in the fetus, but are less concerning in the first few weeks post-conception. Conversely, untreated chronic conditions like hypertension, epilepsy, or depression pose their own risks to the fetus. The safest option is not always stopping the drug, it is often optimizing to the safest effective therapy. Lactation physiology. In lactation, the question is, how much gets into the milk? We look for drugs with high protein binding, low lipid solubility, and high molecular weight. These characteristics keep the drug in the mother's blood and out of the milk. Counseling should be practical. If a drug has a short half-life, suggest pump and dump strategies or timing the dose immediately after breastfeeding to minimize infant exposure. Your confidence here is contagious. If you are unsure, the mother will likely stop breastfeeding or stop the medication, neither of which may be necessary. Figure: a risk-benefit decision matrix for pregnancy. The x-axis represents severity of maternal condition and the y-axis represents teratogenic risk of drug. Quadrants show actions: continue therapy, high maternal risk, low drug risk, switch agent, high maternal risk, high drug risk, and discontinue, low maternal risk, high drug risk. A side graphic shows the timing strategy for breastfeeding relative to drug half-life. 7.5 Renal and hepatic impairment, dose adjustments and contraindications. The kidneys and liver are the exit doors for pharmacotherapy. When these doors are blocked, drugs accumulate to toxic levels. For the PEBC, you must be proficient in recognizing when a standard dose becomes a poison. Renal function and the Cockcroft-Gault equation. While laboratories report eGFR, estimated glomerular filtration rate, most drug monographs still base dose adjustments on the Cockcroft-Gault equation for creatinine clearance, CRCL. In an exam setting, you must know which formula to use. For patients with very low muscle mass, like the elderly, serum creatinine may be artificially low, leading to an overestimation of renal function. Drugs like gabapentin, allopurinol, digoxin, and DOACs, direct oral anticoagulants, require strict renal vigilance. A patient with a CRCL less than 30 ml per minute on a full dose of rivaroxaban is at a massive risk for hemorrhage. Always check the kidney function before dispensing these agents. Hepatic impairment. Unlike renal failure, we lack a precise mathematical filter like CRCL for the liver. We rely on the Child-Pugh classification, which looks at synthesis, albumin, INR, and complications, ascites, encephalopathy. Hepatic impairment affects drugs metabolized by the CYP450 system. Be wary of prodrugs, which may not activate, and highly protein-bound drugs, which may become free fractions if albumin is low. When in doubt with a cirrhotic patient, the adage "start low and go slow" is a clinical mandate, not just a suggestion.
Chapter 8, Canadian Pharmacy Law and Jurisprudence. Sections, Section 8.1, the Federal Framework, Food and Drugs Act vs. CDSA, Section 8.2, Controlled Substances, Targeted Substances, Narcotics, and Benzodiazepines, Section 8.3, Privacy Legislation, PEPCD and Protecting Patient Health Information, Section 8.4, Ethical Frameworks, Beneficence, Non-Maleficence, and Patient Autonomy, Section 8.5, Scope of Practice, Prescribing Authority, Injections, and Adaptations. In Chapter 7, we focused on the nuance of customization, adapting therapies for the young, the old, and the medically complex. We learned that clinical judgment is rarely black and white. Now, we step into the world of boundaries. If clinical therapeutics is the engine that drives patient care, jurisprudence is the set of guardrails that keeps the vehicle on the road. For many candidates, especially international pharmacy graduates, IPGs, this chapter feels the most foreign. Science is universal, physiology does not change across borders. However, laws are deeply territorial. They define not only what you can do, but what you must do to protect the public. The PEBC exams test this rigorously. In an OSCE, you might identify the perfect drug clinically, but if you dispense a narcotic on a verbal order where it is prohibited, you have failed the station. This chapter is about protecting your license and, more importantly, protecting your patients from harm and privacy breaches. We will navigate the hierarchy of Canadian law, from federal statutes that classify drugs to the ethical frameworks that guide your decisions when the law is silent. Let's demystify the rules of engagement. 8.1 The Federal Framework, Food and Drugs Act vs. CDSA. The foundation of Canadian pharmacy practice rests on two massive federal pillars. Understanding the difference between them is critical for answering multiple choice questions, MCQs, regarding drug scheduling and prescription requirements. Think of the Food and Drugs Act, F&DA, as the standard of quality. It is concerned with safety, efficacy, and labeling. It classifies drugs into schedules, like Schedule F for prescription drugs, based on how much supervision a patient needs to use them safely. On the other hand, the Controlled Drugs and Substances Act, CDSA, is the standard of control. It is criminal law. It is concerned with addiction, abuse potential, and diversion. If a drug falls under the CDSA, the rules become significantly stricter regarding filing, storage, and record keeping. When you are assessing a prescription, you must ask, is this just a prescription drug, F&DA, or is it also a controlled substance, CDSA? Figure A. Detailed conceptual illustration of two large marble pillars supporting a lintel-labeled Canadian pharmacy practice. The left pillar is labeled Food and Drugs Act, Safety, and features icons of safety seals, chemical structures, and prescription pads. The right pillar is labeled CDSA, Control, and features icons of heavy padlocks, chains, and scales of justice. Between them stands a pharmacist in a white coat, balancing a book labeled Compliance. The lighting is warm and professional, emphasizing stability and structure. High resolution, realistic style. If it is purely under the F&DA, like amoxicillin or Lipitor, your main concern is clinical appropriateness and proper authorization. You have more flexibility with transfers and verbal orders. If it falls under the CDSA, like Percocet or Adderall, your focus shifts to strict accountability. You are now a gatekeeper preventing diversion. The PEBC loves to test the specific administrative differences between these two categories. 8.2 Controlled Substances, Targeted Substances, Narcotics, and Benzodiazepines. This section causes the most confusion because the terminology is specific. In Canada, we categorize controlled substances into subsets that have different rules. You need to memorize the distinction between a narcotic, a verbal prescription narcotic, and a targeted substance. Narcotics, straight narcotics. These contain a single narcotic ingredient, e.g., morphine, oxycodone, or a narcotic with only one non-medicinal ingredient. These represent the highest risk of abuse. Asterisk key rule, no verbal prescriptions allowed, except in very specific palliative emergencies in some jurisdictions, but generally no. Asterisk filing, must be filed separately from regular prescriptions. Verbal prescription narcotics, these are combinations of a narcotic with 2 or more non-narcotic medicinal ingredients, e.g., acetaminophen with codeine and caffeine. Asterisk key rule, verbal orders are permitted. Asterisk refills, not allowed. You can only dispense part fills if the total quantity is authorized at the start. Targeted substances, this category primarily includes benzodiazepines, e.g., lorazepam, diazepam, and similar agents like zolpidem. Asterisk key rule, verbal orders are permitted. Asterisk refills, allowed, but the prescription is only valid for 1 year from the date prescribed. Asterisk transfers, can only be transferred once. Figure, a clear, color-coded decision tree flow chart titled, Processing Controlled Substances. The starting node is the drug a controlled substance? Branch 1, straight narcotic -red box written only, no refills. Branch 2, verbal narcotic, combo -orange box verbal OK, no refills, part fills only. Branch 3, targeted substance, benzos -a yellow box verbal OK, refills OK, transfer once. The background is a clean white and medical blue gradient. Clean vector graphics. For the PEBC, pay close attention to filing requirements. 1. Straight narcotics, filed separately. 2. Controlled drugs, Part 1, 2, 3 filed separately. 3. Targeted substances, can be filed with regular prescriptions or separately, check provincial nuances, but federal law allows integration. Remember the part fill versus refill distinction. You cannot refill a narcotic. You can only dispense the remaining balance of a total authorized quantity. This semantic difference is often the answer key in a trick question. 8.3 Privacy legislation, PEBC and protecting patient health information. In the digital age, health information is as valuable as currency. In Canada, the Personal Information Protection and Electronic Documents Act, PEBC, sets the federal standard for how private sector organizations manage personal data. While many provinces have their own health privacy acts, like FIPA in Ontario, that supersede PEBC if they are substantially similar, the core principles remain the same for the PEBC exams. Consent is king. You cannot collect, use, or disclose personal health information, PHI, without knowledge and consent. In the pharmacy, consent is often implied within the circle of care, e.g., discussing a patient's medication with their prescriber. However, consent must be explicit, when sharing information outside that circle, such as with an insurance company for a reason unrelated to the claim, or with a family member who is not the patient's agent. The circle of care analogy, imagine a circle drawn around the patient. Inside are the doctors, nurses, and pharmacists directly treating them. Information flows freely here to ensure safety. Outside the circle are employers, teachers, and curious neighbors. The wall between the inside and outside is solid lead. Practical tips for the OSCE, *identity verification, always ask who is picking up the medication. *discretion, never shout a drug name, here is your Viagra, across a crowded counter. *data minimization, only collect the information you strictly need to do your job. Figure, a visual diagram of the circle of care. In the center is a patient silhouette. Surrounding them in a blue circle are icons of a doctor, pharmacist, and nurse. Arrows show data flowing freely between them. Outside the circle, separated by a shield icon, are icons representing an employer, a neighbor, and a marketing agency with red X marks over the connection lines. Minimalist, modern infographic style. 8 point for ethical frameworks, beneficence, non-maleficence, and patient autonomy. Laws tell you what you must do. Ethics tell you what you should do when the laws don't give a clear answer. The PEBC creates scenarios where legal requirements are met, but an ethical dilemma remains. You must balance for fundamental principles. Beneficence, to do good acting in the patient's best interest. Example, ensuring a patient understands how to use their insulin so they don't get hypoglycemia. Non-maleficence, to do no harm, avoiding negligence or harmful interventions. Example, refusing to fill a prescription for a contraindicated drug that could kill the patient, even if the doctor insists. Autonomy, self-determination, respecting the patient's right to choose, provided they are capable and informed. Example, a capable patient refusing a life-saving antibiotic. You may not like it, but you must respect it after ensuring they understand the consequences. Justice, fairness, allocating resources fairly. Example, triaging patients in a busy pharmacy based on clinical urgency rather than who pays the most. The conflict of autonomy and beneficence, this is the most common OSCE conflict. A patient wants a natural health product that interacts with their chemotherapy, autonomy. You want to stop them to save their life, beneficence. Your role is not to force them. Your role is to provide high-quality information so their autonomy is informed. If they are capable and informed, they have the right to make what you consider a bad decision. 8.5 Scope of practice, prescribing authority, injections, and adaptations. We are currently in a golden age of pharmacy evolution in Canada. The scope of practice has expanded from dispensing to prescribing for minor ailments, renewing prescriptions for continuity of care, and administering injections. However, scope of practice is determined provincially. For the PEBC, which is a national exam, you must understand the general principles of expanded scope rather than memorizing the specific list of ailments for Saskatchewan versus Nova Scotia. Adaptations, this is the ability to alter a prescription to meet the patient's needs. Asterisk dose formulation change, changing a tablet to a liquid for a patient who cannot swallow. Asterisk regimen change, adjusting dosing frequency to improve adherence. Asterisk therapeutic substitution, swapping a drug for another in the same class, permitted in some provinces, but usually requires strict protocols. Prescribing authority, most provinces now allow pharmacists to prescribe for minor ailments, like UTIs, cold sores, or allergies, and for smoking cessation. The key legal requirement here is documentation and notification. You must notify the primary care provider to maintain the continuity of the health record. The red flags of scope, just because you can do something doesn't mean you should. Asterisk do not adapt a prescription if you do not have the original order or sufficient information. Asterisk do not prescribe for a condition that masks a more serious underlying diagnosis, e.g., treating a red eye that is actually glaucoma. Asterisk always refer when the condition is outside your knowledge base or scope. Figure, a split-screen illustration showing scope of practice. On the left, a checklist labeled requirements includes items like private counseling room, access to labs, and proper training. On the right, a pharmacist is shown engaging in 3 activities: injecting a vaccine, writing a prescription adaptation, and counseling a patient. The image conveys professional empowerment grounded in responsibility. Realistic, high-detail style. In the next chapter, we will shift away from the rules and regulations to look at the tools of the trade, drug information resources. Understanding the law is vital, but knowing where to find the answers when you are stumped is just as important.
Chapter 10, Chapter 9, Medication Safety and Professional Practice. Sections, Section 9.1, Preventing Medication Errors, Root Cause Analysis and Safety Culture, Section 9.2, Drug Interactions, Cytochrome P450 Inducers, Inhibitors, and Substrates, Section 9.3, Compounding Essentials, NAPRA Standards for Sterile and Non-Sterile Preparations, Section 9.4, Evidence-Based Medicine, Interpreting Biostatistics and Clinical Trials, Section 9.5, Interprofessional Collaboration, Communicating with Prescribers and Nurses. In Chapter 8, we navigated the rigid guardrails of Canadian jurisprudence, defining the legal boundaries that dictate what a pharmacist must do. Now, we step inward to the very core of your daily practice. If the law provides the rules of the road, medication safety is your defensive driving skill set. This chapter bridges the gap between knowing the rules and applying them to protect human life. In the rush of a busy dispensary, the law won't stop a drug interaction, your vigilance will. For the PEBC, This is where knowledge transforms into competence. It is not enough to know the drug, you must ensure it does no harm. We will move beyond rote memorization into the systems, calculations, and communication strategies that define a safe practitioner. From the microbiology of sterile compounding to the psychology of talking to a frustrated physician, this is the how-to manual for professional excellence. Let's build your safety net. 9.1 Preventing medication errors, root cause analysis and safety culture. The old approach to medication errors was simple and destructive. Who messed up? This blame and shame culture drove errors underground, ensuring they would happen again. In Canada, and specifically for the PEBC, you must adopt a systems thinking mindset. We do not look for bad people, we look for broken processes. Medication safety relies on the understanding that human error is inevitable, but patient harm is preventable. When an error occurs, whether it's a near miss or a critical incident, your role is to investigate the environmental and procedural factors that allowed the slip to pass through the cracks. The Swiss cheese model. The most enduring analogy in safety science is the Swiss cheese model. Imagine every layer of defense, the prescriber check, the computer alert, the technician's count, your clinical verification, as a slice of cheese. No slice is perfect, each has holes. An error only reaches the patient when the holes in every slice align perfectly. Your job is not to be a perfect, hole-free slice, which is impossible, but to add enough layers and minimize the holes so the light never shines all the way through. Root cause analysis, RCA. Figure, clean, flat vector illustration of the Swiss cheese model specific to pharmacy. 4 slices of cheese lined up. Label slices, prescribing, dispensing, administration, monitoring. A red arrow, the error, passes through holes in the first 3 but is stopped by the 4th slice, pharmacist counseling. White background, professional blue and yellow color palette. When a mistake happens, we conduct a root cause analysis. This is a retrospective tool used to identify the underlying problems. For the exam, remember that retraining the staff is rarely the strongest solution because it relies on memory, which is fallible. Stronger interventions involve forcing functions or hard stops. For example, if 2 lookalike drugs are constantly confused, a weak solution is telling staff be more careful. A strong solution is physically separating them on the shelf or requiring a barcode scan that makes it impossible to proceed with the wrong bottle. ISMP Canada and reporting. You must be familiar with the Institute for Safe Medication Practices, ISMP, Canada. They are the lighthouse for medication safety in this country. Reporting incidents to ISMP, via the CMIRPS program, is not an admission of guilt, it is a professional obligation to share learning. In an OSCE scenario, if you discover an error, your immediate priority is the patient's welfare, followed by transparent disclosure. Never hide an error. Apologize, explain what happened, without blaming staff, and explain the systemic changes you will implement to prevent recurrence. 9.2 Drug interactions, cytochrome P450 inducers, inhibitors, and substrates. If the body is a factory, the liver is the waste management department, and the cytochrome P450, CYP450, enzymes are the shredders. Understanding this system is non-negotiable for Canadian licensure. You will face scenarios where a patient's chronic medication is destabilized by a seemingly harmless new prescription. Most drug interactions in this category boil down to one mechanism, altering the speed of the shredder. If you speed up the shredder, induction, the drug disappears too fast, leading to therapeutic failure. If you unplug the shredder, inhibition, the drug accumulates, leading to toxicity. The inhibitors, GPACMan. Inhibitors act quickly. If you give a strong inhibitor, the enzymatic blockade happens almost immediately, causing substrate levels to spike. Think of this as a traffic jam. The cars, drugs, cannot leave the highway, so they pile up. Common strong inhibitors include grapefruit juice, protease inhibitors, azole antifungals, cyclosporine cimetidine, macrolides, clarithromycin, but not azithromycin, amiodarone, and non-DHP calcium channel blockers, diltiazem verapamil. Critical clinical pearl. When an inhibitor is added. Substrate concentration increases. Risk, toxicity. Onset, fast, often within 24 to 48 hours. Example, adding clarithromycin to a patient on atorvastatin. Result, simvastatin levels spike. Risk of rhabdomyolysis. Action, hold statin during antibiotic course. The inducers, PS porks. Inducers are slower. They work by telling the liver to build more enzymes. This construction project takes time, so the effect of an inducer may not be fully seen for 2 to 3 weeks. Conversely, when you stop an inducer, it takes time for those extra enzymes to degrade. Common inducers include phenytoin, smoking, phenobarbital, oxcarbazepine, rifampin, carbamazepine, and St. John's wort. If a patient on an oral contraceptive starts taking St. John's wort, the estrogen is metabolized too quickly, leading to contraceptive failure. Managing the interaction. For the PEBC, simply identifying the interaction is not enough. You must provide a management strategy. Can you monitor? Do you need to adjust the dose? Is the combination strictly contraindicated? For narrow therapeutic index drugs like warfarin, lithium, or digoxin, you rarely leave it to chance. If an interaction is probable, you either switch the offending agent or preemptively adjust the dose and schedule close monitoring. 9.3 Compounding Essentials, NAPRA Standards. Compounding is the art of pharmacy, but in Canada, it is regulated by rigorous science. The National Association of Pharmacy Regulatory Authorities, NAPRA, sets the standards. IPGs often find this section challenging because regulations here may be stricter than in other jurisdictions. We divide compounding into non-sterile and sterile. The guiding principle for both is the protection of personnel and the patient. You must know the difference between protecting the product from you and protecting you from the product. Non-sterile preparations. This covers creams, ointments, suspensions, and capsules. NAPRA categorizes compounding into 3 levels based on complexity and risk. Level A is simple, reconstituting antibiotics. Level B is complex, making a capsule from bulk powder. Level C involves hazardous materials. A critical concept for the exam is the master formulation record versus the compounding record. The master record is the recipe, the theoretical standard. The compounding record is the log of what you actually did today, the lot numbers, weights, and signature. Sterile preparations, NAPRA model standards. This is high-stakes territory. 4 bags, eye drops, and injectables must be sterile. The environment is controlled by ISO, International Organization for Standardization, class ratings. The lower the ISO number, the cleaner the air. The primary engineering control, PEC, usually the laminar airflow hood, must be ISO Class 5. The buffer room, where the hood sits, must be ISO Class 7. The anteroom, where you wash hands, is ISO Class 8. Air flows from the cleanest area out to the dirtiest area to push contaminants away. Hazardous compounding. Figure, 3D cutaway diagram of a sterile compounding suite. Show 3 distinct zones, anteroom, ISO 8, buffer room, ISO 7, and the laminar flow hood, ISO 5. Arrows indicate airflow direction from ISO 5 outward to ISO 8. Include a pharmacist figure garbed in PPE, gown, mask, gloves, hairnet, working in the hood. When handling hazardous drugs, chemotherapy, hormones, the rules flip. We need negative pressure. We want to keep the toxic air in the room so it doesn't escape into the pharmacy. The hood, biological safety cabinet, must vent to the outside, and you must use a closed system transfer device, CSTD, when possible. 9.4 Evidence-based medicine, interpreting biostatistics. Do not let the math scare you. In clinical practice and on the PEBC, biostatistics is not about calculating formulas by hand, it is about interpreting the literature to make safety decisions. You are the filter between a pharmaceutical sales pitch and patient truth. We focus on 3 pillars. Validity, is the study true? Clinical relevance, does it matter? And applicability, does it fit my patient? P-values and confidence intervals. The p-value tells you about chance. A p-value less than 0.05 means there is less than a 5% probability that the results happened by random luck. However, statistical significance does not equal clinical significance. A drug might lower blood pressure by 1 mm of mercury with a p-value of 0.001. It's real, but does it matter? Likely not. Confidence intervals, CI, are often more useful. They give you the range. If a study reports a relative risk, RR, of 0.8 with a 95% CI of 0.6 to 1.1, look at the number 1. Because the range crosses 1, the point of no difference, the result is not statistically significant. NNT and NNH. The number needed to treat, NNT, is the most practical metric for a pharmacist. It tells you how many people need to take a drug for one person to benefit. We want this number low. An NNT of 5 is excellent. An NNT of 100 means 99 people take the drug with no benefit to the primary outcome. Conversely, the number needed to harm, NNH, tells you the risk. We want this number high. If the NNT is 5 and the NNH is 5, the drug causes as many problems as it solves. This risk-benefit analysis is central to evidence-based medicine. 9.5 Interprofessional collaboration, communicating with prescribers. The days of the silent pharmacist are over. Modern safety depends on your ability to challenge prescribers respectfully and clearly. IPGs specifically are tested on this in the OSCEs. The grader is looking for assertiveness tempered with professional courtesy. You must avoid being passive, I think maybe this dose is high, and avoid being aggressive, you wrote this wrong. Instead, be collaborative and evidence-based. The ISBAR technique. When calling a physician or nurse, use the ISBAR format. It structures your thoughts and commands respect because it respects the prescriber's time. I. Introduction, who you are and where you are calling from. S. Situation, the immediate problem, e.g., Mrs. Smith has a potential interaction between X and Y. B. Background, the clinical context, e.g., she just started amiodarone today and takes warfarin. A. Assessment, your clinical analysis, e.g., this combination will likely elevate her INR significantly within 48 hours. R. Recommendation, the specific action you want, e.g., I recommend reducing the warfarin dose by 25% and rechecking INR in 3 days. Do you agree? Handling disagreement. If a prescriber rejects your recommendation, do not simply hang up. You have a duty to the patient. Ask for their rationale. Can you help me understand your goal with this high dose? If the safety risk is severe, you have the right and the obligation to refuse to dispense. In Canada, your license is your own. You cannot hide behind the doctor told me to do it if a patient is harmed by a clear error you should have caught. OSCE tip. If a doctor in a role-play says, just fill it, I'm the doctor, do not yield if safety is compromised. Correct response, I respect your decision, Dr. Lee, but I cannot dispense this prescription as written because the risk of respiratory depression is too high. I am happy to dispense a safer alternative, or we can discuss a lower dose. Safety is not an accident, it is a habit. By mastering these systems, from the mechanics of the CYP450 enzymes to the diplomacy of the ISBAR protocol, you become the reliable safety net that Canadian patients deserve.
Chapter 10, Conquering Part 1, MCQ, Test-Taking Tactics. Section 10.1, Anatomy of a PEBC question, Identifying Distractors and Key Qualifiers, Section 10.2, Time Management Strategies for the Computer-Based Exam, Section 10.3, Managing Uncertainty, Educated Guessing and Process of Elimination, Section 10.4, Case-Based Scenarios, Synthesizing Lab Values and Patient History Quickly. In Chapter 9, we focused on the culture of safety, the defensive driving skills required to protect patients in a real-world dispensary. We discussed systems, checks, and the crucial mindset that prevents harm before it happens. Now, we must translate that safety-first mindset into the artificial environment of the examination hall. You have spent the previous chapters building your clinical arsenal. You understand that software of the nervous system, the warfare of infectious disease, and the guardrails of jurisprudence. However, possessing knowledge and demonstrating it on a standardized test are two different skills. The PEBC Qualifying Exam Part 1, MCQ, is not merely a memory test, it is a simulation of clinical decision-making under pressure. The exam does not just ask, what is the dose? It asks, given this complex, imperfect situation, what is the best move? This chapter is your tactical manual for decoding that logic. We will strip away the anxiety of the correct answer and replace it with a systematic approach to finding the best answer. We will dissect the anatomy of the questions, manage the scarcity of time, and learn how to triage information just as you would in a busy emergency room. 10.1 Anatomy of a PEBC question, identifying distractors and key qualifiers. Figure A. Detailed, schematic-style illustration of a PEBC exam question anatomy. The image should resemble a blueprint or architectural drawing on a dark blue background with white lines. The central element is a sample pharmacy multiple-choice question broken into labeled parts: the stem, patient history, the lead-in, the actual question, the key qualifiers, words like most, except glowing in neon orange, and the options A, B, C, D. Arrows point to specific distractors that labeled as plausible but incorrect. The style should be clean, technical, and high contrast. A PEB question is a constructed logic puzzle, not a random query. Every word in the stem, the patient case or background info, serves a purpose. It either rules in a diagnosis, rules out a drug, or acts as noise to test your ability to filter irrelevant data. Your first task is to identify the lead-in. This is the actual question at the end of the scenario, such as which of the following is the most appropriate initial therapy. Do not read the case first, read the lead-in first. This primes your brain to look for specific data points, e.g., allergies, renal function, or age, while you read the scenario. Next, you must hunt for qualifiers. These are the words that change the rules of the game. Words like initial, maintenance, prophylaxis, most, and except completely alter the correct answer. If the question asks for the initial therapy for a migraine, the answer is an NSAID or triptan. If it asks for prophylaxis, the answer might be propranolol or topiramate. Identifying the distractors. In a standard 4-option multiple-choice question, there is usually one correct answer and 3 distractors. However, in Canadian pharmacy licensing, distractors are rarely wrong in the sense of being nonsensical. They are often correct for a different patient or correct for a different stage of the disease. One distractor will likely be the layman's trap, an answer that sounds good to the public but is clinically weak, e.g., recommending a multivitamin for fatigue without investigation. Another distractor is often the fatal flaw, a drug that treats the condition effectively but is contraindicated for this specific patient, e.g., an effective antibiotic that causes anaphylaxis in this case. Recognizing these patterns protects you. When you see 2 answers that look correct, ask yourself, is one of these a fatal flaw due to a kidney issue or interaction hidden in the stem? This reframes the choice from guessing to safety checking. 10.2 Time Management Strategies for the Computer-Based Exam. The PEBC is a marathon, not a sprint, but it is a marathon run against a stopwatch. You generally have roughly 1 minute per question. This sounds sufficient, but when you account for reading long case scenarios, fatigue, and second guessing, that minute evaporates quickly. The most dangerous trap is the sunk cost fallacy. This occurs when you spend 3 minutes on a difficult calculation question because you feel you are almost there. Those 3 minutes cost you the opportunity to answer 2 easy recall questions later in the exam. You must adopt a triage mindset. If you read a question and do not know the answer, or if the calculation looks incredibly complex, flag it and move on immediately. The computer interface allows you to return to flagged questions. It is better to guess on 3 hard questions at the end than to run out of time and leave 5 easy questions blank. The 2-pass technique. Figure, a minimalist infographic showing a time management flowchart for exam taking. The background is white with sleek black and green arrows. Step 1, read lead-in. Step 2, do I know the concept? Branch A, yes, answer and verify. Branch B, no or unsure, flag and skip. Branch C, calculation, is it quick? Dash a yes, no decision tree. A clock icon in the corner shows a countdown timer with sectors highlighted in green, safe zone, yellow, caution, and red, rush, dot. I strongly recommend the 2-pass technique for the PEBC. On your first pass through the exam, answer only the questions you know immediately and the calculations that can be done in under 30 seconds. This builds momentum and confidence while securing the LESE marks early. On your second pass, return to the flagged questions. Now, your subconscious has had time to process them, and the pressure of finishing is lower because the bulk of the exam is done. This prevents the panic that occurs when you look at the clock and realize you have 20 questions left and only 10 minutes. 10.3 Managing Uncertainty, Educated Guessing and Process of Elimination. You will encounter questions where you simply do not know the answer. This is a statistical certainty. Do not let this rattle your confidence. It happens to every pharmacist who has ever written this exam. The goal here is to improve your odds from 25%, random guessing, to 50% or higher. Use the process of elimination, POE, aggressively. Start by crossing out options that are clearly unsafe or irrelevant. Usually, you can eliminate 2 options quickly, one that treats the wrong disease and one that is the wrong drug class. This leaves you with 2 similar options. This is where clinical intuition comes in. If you are stuck between 2 doses, the lower dose is often the safer, more conservative answer for an initial therapy question. If you are stuck between a brand new expensive drug and an older generic, the exam often favors the tried and true guideline-based therapy unless there is a specific reason to switch. Scenario type guessing heuristic, rule of thumb. 10-point for case-based scenarios, synthesizing lab values and patient history quickly. Case-based questions are the most intimidating part of the exam because of the sheer volume of text. You might see a full page containing presenting complaints, history of present illness, HPI, past medical history, medication lists, and a table of lab values. Do not read the case like a novel. Read it like a detective scanning for clues. As mentioned in section 10.1, read the question, lead-in, first. If the question asks about a drug interaction between the patient's heart medication and a new antibiotic, you can ignore the section on their history of arthritis. When scanning lab values, use a mental filter. You do not need to memorize the exact decimal point of every reference range, as ranges are often provided. Instead, scan for outliers. Is the potassium high or low? Is the creatinine clearance normal or reduced? Is the INR within target? Synthesizing the big picture. Figure, a dynamic, X-ray vision style illustration of a medical case study. The text of a patient history is blurred out in gray, except for specific glowing keywords that a pharmacist would focus on: penicillin allergy, CRCL 25 ml per minute, pregnant, and chief complaint, rash. A magnifying glass hovers over the lab value section, highlighting K plus 6.2 millimoles per liter in red. This visualizes the concept of selective reading and filtering data. Once you have isolated the key variables, e.g., elderly patient plus low kidney function plus need for pain relief, synthesize them into a single clinical sentence. I need a painkiller for an 80-year-old with bad kidneys. Now, look at your options. A. Ibuprofen, NSAID, bad for kidneys, elderly. B. Imiperidine, toxic metabolite, bad for kidneys, elderly. C. Acetaminophen, safe for kidneys, elderly. D. Morphine, active metabolites accumulate in renal failure. By simplifying the case to its core conflict, renal versus pain, the answer, acetaminophen, becomes obvious, even if you didn't memorize every specific contradiction for the other drugs. You solved it by synthesis, not just memorization. This exam is designed to test your competence, not your perfection. You have the knowledge base from our previous chapters. Now, by applying these tactics, dissecting the stem, managing your clock, narrowing your choices, and filtering the noise, you can ensure that your knowledge shines through the format.
Chapter 11, Mastering Part 2, OSCE, Clinical Skills. Section 11.1, The 7-Minute Station Structure, Timing your interaction perfectly. Section 11.2, Communication Framework, Empathy, Open-ended Questions, and Active Listening. Section 11.3, Solving the Non-Drug Problem, Counseling on Devices and Lifestyle. Section 11.4, Handling Difficult Interactions, Angry Patients, Doctors, and Ethical Dilemmas. Section 11.5, The Interactive Checklist, Ensuring Safety Nets and Follow-up Plans. In Chapter 10, we dissected the mechanics of the multiple-choice exam, treating it as a strategic game of logic and probability. You learned to navigate the silent, solitary environment of the MCQ. Now, we must step out of that silence and onto the stage. The Objective Structured Clinical Examination, OSCE, is not a test of what you know, it is a test of who you are as a professional. For many candidates, particularly international pharmacy graduates, IPGs, the shift from the paper-based Part 1 to the performance-based Part 2 is jarring. You can no longer hide behind a pencil. You must demonstrate knowledge, empathy, and safety in real time, while a stranger watches and grades your every move. This chapter is about performance anxiety and execution. We are moving from the what, clinical knowledge, to the how, clinical application. The goal here is to transform you from a student who knows the answers into a clinician who can manage the room. 11.1 The 7-minute station structure, timing your interaction perfectly. Figure, photorealistic style, eye-level perspective. A modern, brightly lit pharmacy exam room. A pharmacy student in a white coat stands attentively facing a standardized patient, actor, who looks anxious. In the corner, an examiner sits with a clipboard, observing but not interacting. The focus is on the student's open body language and eye contact. Soft, professional lighting. The greatest enemy in the OSCE is not the difficult patient, it is the clock. 7 minutes feels like an eternity when you are silent, but it vanishes in seconds when you are counseling. To pass, you must internalize the rhythm of the station. The interaction actually begins before you enter the room. You are given 2 minutes to read the prompt posted on the door. This is your loading phase. Do not passively read the paper, aggressively extract the data. Identify the patient's age, the chief complaint, and the task at hand, e.g., counsel this patient versus solve the drug therapy problem. Once the bell rings and you enter, the clock starts. I recommend a 2-3-2 pacing strategy for a standard interactive station. Spend the first 2 minutes gathering information. You cannot solve a problem you do not fully understand. The middle 3 minutes are for the intervention. This is where you educate, correct the issue, or provide the recommendation. This is the meat of the encounter. The final 2 minutes are for closing and safety netting. Many students fail because they are still explaining the mechanism of action when the final bell rings. You must leave time to verify understanding. 11.2 Communication Framework, Empathy, Open-ended Questions, and Active Listening. Communication in the OSCE is graded technically. Being nice is not the same as clinical empathy. The examiners are listening for specific verbal cues that demonstrate you are validating the patient's experience. Avoid the robotic "I understand how you feel." If a patient says they are terrified of needles, and you say "I understand," you are lying, you are not them. Instead, use reflective listening. It sounds like the idea of injection is really causing you anxiety. Use the funnel technique for questioning. Start broad with open-ended questions to get the patient talking, then narrow down to closed-ended questions to confirm specific safety details. The funnel technique. 1. Open, the broad top "How have you been managing your headaches so far?" 2. Clarifying, the middle "You mentioned Tylenol, how many tablets do you take at once?" 3. Closed, the narrow tip "Do you have any liver problems?" Active listening requires silence. When the actor pauses, wait 2 seconds before speaking. Often, the actor has a script point they are waiting to deliver, but they will only drop that clue if you give them space. Rushing to fill the silence kills the interaction. 11.3 Solving the non-drug problem, counseling on devices and lifestyle. Figure, infographic style, clean vector art. A circular flowchart depicting the loop of active listening. Step 1. Patient speaks, sound waves icon. Step 2. Pharmacist pauses, pause button icon. Step 3. Pharmacist reflects validates, mirror icon. Step 4. Patient confirms, checkmark icon. Arrows connect the steps in a continuous cycle. Color scheme, professional blue and teal. Pharmacy is not just about pills. A significant portion of OSCE stations involve devices, inhalers, EpiPens, glucometers, or spacers. If you know the pharmacology of albuterol but cannot demonstrate how to prime the inhaler, you will fail the station. This requires physical fluency. You must be comfortable handling the props. During your study practice, buy placebo inhalers or use empty devices. Your hands should know what to do without your brain telling them. When counseling on lifestyle, avoid being preachy. Telling a smoker smoking is bad is a waste of breath, they know that. Instead, focus on the how. Connect the lifestyle change directly to their specific complaint. For example, if a patient has reflux, do not just list GERD triggers. Say, you mentioned your heartburn is worse at night. Raising the head of your bed by 6 inches can physically stop the acid from traveling up while you sleep. The show and tell rule. Never just talk about a device. Pick it up. Demonstrate it on yourself, without putting it in your mouth, then hand it to the patient and ask them to show you. This teach-back method is often a mandatory checklist item for full marks. 11.4 Handling difficult interactions, angry patients, doctors, and ethical dilemmas. You will face conflict. The PEBC specifically writes scenarios with angry patients, rushing doctors, or ethical traps to test your composure. When a patient yells, your instinct may be to defend yourself or apologize profusely. Do neither. If a patient is angry about a wait time or a mistake, acknowledge the emotion immediately. I can see you are incredibly frustrated, and I want to help resolve this right now. Do not make excuses. Pivot to the solution. With a rushing doctor, physician interaction station, brevity is your weapon. Do not walk them through your thought process. Give them the SBAR headline, situation, background, assessment, recommendation. SBAR example for a physician call. Situation: Dr. Smith, I am calling about Mrs. Jones's prescription for warfarin. Background: she was just prescribed Bactrim for a UTI. Assessment: this combination will spike her INR and increase bleed risk. Recommendation: I recommend switching the antibiotic to nitrofurantoin. Ethical dilemmas are binary. You either uphold the law ethics, or you don't. If a scenario asks you to dispense a narcotic early without a valid reason, the answer is no. The test is not whether you can make the customer happy. The test is whether you can say no professionally and offer a safe alternative. 11.5 The interactive checklist, ensuring safety nets and follow-up plans. Figure, split-screen illustration. Left side, a pharmacist looking flustered and defensive as a patient yells, labeled defensive incorrect. Right side, the same pharmacist looking calm, leaning slightly forward with an open palm gesture, while the patient looks hurt and calmer, labeled de-escalation correct. Visual cues emphasize body language and facial expression. Every station has a mental checklist the examiner is marking. The most commonly missed section is the safety net. You might give the perfect drug and the perfect instructions, but if you do not tell the patient what to do if things go wrong, you are practicing unsafely. Develop a universal closing script that covers the 3 Ws. 1. What to expect, efficacy. 2. Worst case scenario, toxicity side effects. 3. When to seek help, monitoring. Before the bell rings, you must ensure the patient has no lingering confusion. Ask, just to be sure I didn't miss anything, can you tell me how you are going to take this medication when you get home? This final check protects the patient and proves to the examiner that you have closed the loop. It transforms a monologue into a dialogue. Remember, the OSCE is a performance of competence. You are the expert in the room. Stand tall, speak clearly, and treat the actor like a real human being who needs your help.
Chapter 12, The Final Review and Exam Day Logistics. Sections, Section 12.1, The Simulation Phase, Running Full-Length Mock Exams, Section 12.2, Rapid Review Cheat Sheets, Mnemonics for Drugs, Antidotes, and Labs, Section 12.3, The Week Before, Sleep, Nutrition, and Tapering Study Volume, Section 12.4, The Exam Day Execution, What to Bring, Arrival Procedures, and Mental Focus. In Chapter 11, we stepped onto the stage of the OSCE, transforming your clinical knowledge into a performance of empathy and competence. We discussed the nuances of human interaction and the pressure of being watched. Now, the rehearsals are over. The script is written. We have arrived at the final countdown. This chapter is the bridge between preparation and execution. You have spent months filling your mind with therapeutic guidelines, legal statutes, and safety protocols. However, the PEBC licensure process is not just an academic challenge, it is a test of physiological stamina and psychological resilience. We are shifting gears from acquisition mode, learning new things, to consolidation and maintenance. Imagine an athlete 1 week before the Olympics. They do not start a new, heavy weightlifting regimen. They taper, they visualize, and they ensure their equipment is flawless. This is your taper phase. 12.1 The simulation phase, running full-length mock exams. There is a distinct difference between knowing the answer to a question and having the mental endurance to answer 150 questions in a row. The PEBC qualifying exam part 1 is a marathon, not a sprint. Your brain consumes glucose rapidly during intense concentration, and decision fatigue is a real physiological phenomenon that can degrade your score in the final hour. To combat this, you must run full-length simulations. These are not casual review sessions. You must replicate the hostile environment of the exam hall in the comfort of your home. This means clearing your desk, turning off your phone, and adhering strictly to the time limits. If the exam starts at 9 a.m., your mock exam starts at 9 a.m. If you are not allowed water at your desk during the real MCQ, depending on the specific site rules for that year, do not have it at your desk now. You are conditioning your body to perform under specific constraints. Analyzing the data, not just the score. Figure, a split-screen illustration comparing study mode versus simulation mode. On the left, a cluttered desk with coffee, music headphones, open textbooks, and a phone. On the right, a sterile desk with only HB pencils, an eraser, a timer, and a bubble sheet. The lighting on the right is stark and bright, simulating an exam hall. This visual emphasizes environmental control. When you finish a mock exam, the raw score is the least important metric. The gold lies in the review process. You must analyze every incorrect answer and every lucky guess. Categorize your errors into 3 buckets. 1. Knowledge gap, you simply didn't know the fact. 2. Misreading, you knew the fact but missed a key word like not, except, or a patient allergy. 3. Stamina failure, you knew the answer but you were tired and lost focus. If you find your errors clustering in the final 50 questions, your issue is stamina, not intelligence. This requires more practice exams, not more reading. If your errors are strictly misreading, you need to slow down your reading pace, not speed up your studying. 12.2 Rapid Review Cheat Sheets, Mnemonics for Drugs, Antidotes, and Labs. In these final weeks, do not attempt to learn complex new pathophysiology. If you do not understand the intricate mechanism of action of a third-line antiarrhythmic by now, you are unlikely to master it effectively in 2 days. Instead, pivot to high-yield memorization. There are certain facts that are purely binary, you either know them or you don't. These include therapeutic drug monitoring ranges, antidotes, and specific lab values. These are perfect candidates for rapid review cheat sheets. Create a brain dump sheet. This is a single piece of paper containing the data points you are most afraid of forgetting. The goal is to memorize this sheet so thoroughly that you can write it out from memory the moment the exam starts, on your scratch paper, freeing your working memory for problem solving. The high-yield antidote table. Toxicology questions are common and often require immediate recall. Review this table daily. Poison a drug antidote treatment key clinical pearl. Mnemonics that stick. Figure, a highly organized, handwritten styled cheat sheet graphic. It features colorful mnemonic devices, a diagram of the CYP450 enzyme system with inducers and inhibitors listed, e.g., GPACMan, and a small chart of therapeutic ranges for lithium, digoxin, and phenytoin. The style should look like a high-achieving student's final review notes. Use mnemonics to compress complex lists. For CYP450 inducers, the classic PS porks, phenytoin, smoking, phenobarbital, oxcarbazepine, rifampin, carbamazepine, St. John's wort, saves mental bandwidth. For anticholinergic side effects, the rhyme remains unbeaten, mad as a hatter, confusion, blind as a bat, mydriasis, red as a beet, flushing, hot as a hare, hypothermia, dry as a bone, anhidrosis. Reciting these ensures you don't miss a symptom in a complex case presentation. 12.3 The week before, sleep, nutrition, and tapering study volume. The week before the exam is the taper phase. Your goal is to reach peak cognitive freshness. Many candidates make the fatal mistake of cramming, staying up until 3 a.m. fueled by caffeine. This is physiological sabotage. Your brain consolidates memory during REM sleep. If you cut sleep to study more, you are pouring water into a leaking bucket. You must prioritize sleep hygiene above all else. Resetting the circadian rhythm. If your exam is at 8:30 a.m., you will likely need to wake up at 6 a.m. or earlier. If you have been studying until midnight and waking up at 10 a.m., your body will be in a state of jet lag on exam day. Start shifting your wake-up time back by 30 minutes every day starting 1 week out. Wake up early, expose your eyes to sunlight immediately to reset your cortisol awakening response, and do your mock questions at the exact time the real exam will occur. Nutrition for cognitive endurance. Figure, a tapering strategy graph. The x-axis represents the days before exam, 7 days down to 0. The y-axis represents study volume, hours. The line starts high at day 7 and curves downward, reaching near 0 on the day before the exam. A secondary line labeled as sleep rest starts lower and curves upward, intersecting the study line. This visually reinforces the concept of resting up for the big day. Avoid heavy carbohydrates, pasta, pizza, the night before or for lunch on exam day. The resulting insulin spike and subsequent blood sugar crash can induce brain fog. Stick to complex carbohydrates, healthy fats, and proteins. Think oats, eggs, nuts, and fish. Hydration is critical, but balance it carefully. You do not want to waste precious exam minutes running to the restroom. 12 point for exam day execution, what to bring, arrival procedures, and mental focus. The morning of the exam should be boring. Drama is the enemy of performance. Have your go bag packed the night before? Double-check your candidate ID, your admission ticket, and acceptable identification, usually government-issued photo ID. Dress in layers. Exam centers, whether large convention halls or university classrooms, are notoriously unpredictable. They can be freezing cold or stiflingly hot. Wear a t-shirt, a hoodie, and comfortable pants. Avoid clothing with many pockets if possible, as this slows down security checks. The panic circle. When you arrive at the test center, you will see a phenomenon I call the panic circle. This is a group of nervous students standing outside, frantically quizzing each other on obscure drug interactions or asking, "Did you study the new guideline for H. pylori?" Do not join this circle. Hearing a fact you don't know 5 minutes before the exam will not help you learn it, it will only spike your adrenaline and shatter your confidence. Put on noise-cancelling headphones, listen to calming music, and stand apart. You are in your own zone. The reset button. During the exam, you will inevitably hit a question, or an OSCE station, that goes badly. You might realize the answer 5 seconds after the buzzer sounds. The natural tendency is to panic and carry that frustration into the next question. You must develop a mental reset button. Visualize a physical button. When a section ends, or you turn the page, press it. The previous question no longer exists. You cannot change it. Your entire universe is the question currently in front of you. In the OSCE, this is vital. The rater in Station 5 does not know you failed Station 4. If you walk in looking defeated, you bias them against you. Walk in with a smile, fresh and ready.
Conclusion: Entering the profession. Sections: Section 13.1, Post-exam reflections, handling the waiting period. Section 13.2, Registration and licensing, the final administrative steps. Section 13.3, Life as a pharmacist, continuing education and career pathways. Section 13.4, Final words of encouragement. You are ready to practice. In Chapter 12, we walked through the intense logistics of the final review and the physical demands of exam day. We focused on peaking at the right moment, managing adrenaline, and crossing the finish line of the PEBC qualifying exams. Now, the pencils are down, the timer has stopped, and the simulation is over. You are standing in the quiet aftermath of a monumental effort. 4 years, your identity has been defined by being a student, an intern, or a candidate. You have operated under the scrutiny of preceptors and the rigid criteria of examiners. This final chapter shifts the focus from how to pass to how to practice. We are moving from the theoretical assessment of competence to the real-world application of your license. This is not merely an administrative transition, it is a psychological shift from asking for permission to assuming responsibility. Here, we will navigate the limbo of the waiting period, demystify the final bureaucratic hurdles of Canadian licensure, and prepare you for the reality of your first year in practice. You are no longer preparing for a test, you are preparing for a career. 13.1 Post-exam reflections, handling the waiting period. The period immediately following the PEBC exams is often described by candidates as disorienting. After months of high cortisol focus, the sudden absence of study schedules can feel like a vacuum. It is common to experience a phenomenon known as the post-exam blues or decompression sickness. Your brain has been wired for rapid information retrieval and constant vigilance. When that stimulus is removed, you may feel restless, anxious, or strangely unfulfilled. This is a physiological response to the drop in stress hormones, not a sign that you performed poorly. Avoid the autopsy trap. It is natural to replay specific OSCE stations or MCQ questions in your mind, often highlighting what you missed rather than what you caught. Memory is reconstructive and biased toward negative events. Your recollection of your performance is likely harsher than the reality. Disconnect from the rumor mill. Figure: a detailed, minimalist line art diagram illustrating the post-exam emotional curve. The x-axis represents time, weeks 1 to 8 post-exam, and the y-axis represents anxiety stress levels. The line starts high at exam day, drops sharply to relief, spikes again at week 2 labeled the post-mortem phase, doubt, plateaus at the waiting limbo, and resolves into acceptance notification. Annotations include coping strategies at each peak, such as disconnect from forums and physical recovery. The style is clean, medical textbook aesthetic with blue and grey tones. Online forums and student groups will inevitably fill with speculation immediately after the exam. Candidates will debate the correct answers to controversial questions. Engaging in these discussions offers no benefit. The exam is scored, and the results are out of your hands. Participating in post-exam dissection often breeds unnecessary anxiety. If you discover you missed a question, you cannot change it. If you answered correctly, the validation is fleeting. Protect your mental peace during this waiting period. Use this time to reconnect with the people, hobbies, and physical health that may have been neglected during your preparation. 13.2 Registration and licensing, the final administrative steps. Passing the PEBC qualifying exam is the major milestone, but it does not grant you a license to practice. It grants you the certificate of qualification. You must now navigate the specific requirements of the Provincial Regulatory Authority, PRA, in the province where you intend to practice, e.g., OCP in Ontario, ACP in Alberta. For international pharmacy graduates, IPGs, this distinction is critical. The PEBC certifies your education and competency, the college licenses your practice. These are separate entities with distinct legal mandates. Once you receive your PEBC results, the workflow shifts from academic to administrative. You must ensure your file with the provincial college is active and that all non-clinical requirements are met. The jurisprudence requirement. While we covered the foundations of law in Chapter 8, most provinces require a specific jurisprudence exam separate from the PEBC. This focuses on provincial legislation, distinct schedules of drugs, and local standards of practice. Do not underestimate this step. Provincial acts vary significantly regarding prescriptive authority, injection certification, and minor ailment prescribing. Ensure you are studying the specific bylaws of your target province, as national generalizations no longer apply. Liability insurance and good character. The final barrier to entry involves public protection mechanisms. You will be required to provide proof of personal professional liability insurance. This is non-negotiable. You are entering a profession where you carry liability for your decisions. You will also undergo a criminal record check or a good character declaration. This ensures that the public trust remains intact. Be transparent and timely with these documents, as administrative delays here are the most common cause of licensure gaps. Step action required responsibility. 13.3 Life as a pharmacist, continuing education and career pathways. The day you receive your license, you become a fully autonomous healthcare provider. There is no longer a preceptor to sign off on your decisions. This realization often triggers imposter phenomenon, the feeling that you are underqualified despite your credentials. Recognize that the PEBC exams test entry-level competence. They verify that you are safe to practice, not that you know everything. Your first year of practice is a residency in the real world, where you will learn the nuances of workflow, insurance adjudication, and long-term patient relationships. The commitment to lifelong learning. Pharmacy is a moving target. Guidelines change, new drugs enter the market, and therapeutic approaches evolve. The knowledge you possess today will be partially obsolete in 5 years. Provincial colleges mandate a learning portfolio or continuing professional development, CPD. Do not view this as a box-ticking exercise. It is your ethical obligation to maintain competence. Build a system for staying current. Subscribe to reputable medical journals, attend conferences, and utilize clinical support tools. Your value as a pharmacist lies in the currency and accuracy of your clinical knowledge. Beyond the dispensary counter. Figure, a high-resolution, split-screen infographic titled The Evolution of Practice. On the left, a section labeled Novice Pharmacist shows a figure focusing on a single prescription vial with thought bubbles regarding dosage, interactions, and guidelines. On the right, a section labeled Expert Practitioner shows the same figure looking at the patient, with an expanded web of connections including social determinants, deprescribing opportunities, lab values, and long-term outcomes. The graphic uses a clean, modern vector style with green and slate blue highlighting growth. While many graduates begin in community pharmacy, the profession is vast. Your PEBC certification is a key that opens multiple doors. Hospital pharmacy focuses on acute care, sterile compounding, and interdisciplinary rounds. Primary care networks involves working directly in clinics alongside physicians to manage chronic diseases. Industry and regulatory affairs focuses on drug safety, pharmacovigilance, and policy development. Do not feel confined to your first role. The skills you honed in Chapter 11, communication, problem-solving, and empathy are transferable across the entire healthcare spectrum. 13.4 Final words of encouragement. You are ready to practice. We have journeyed through the intricacies of Canadian law, the defensive driving of medication safety, and the strategic rigors of the MCQ and OSCE. You have equipped yourself with the technical knowledge and the tactical mindset required to succeed. Trust in your preparation. The PEBC exams are designed to filter for safety and competence. If you have followed the methodologies in this guide, internalized the legal boundaries, and practiced the clinical skills, you are not just ready for the exam, you are ready for the profession. When you step behind the counter or onto the ward for the first time as a licensed pharmacist, remember that you are the expert on medication management. Patients will look to you for clarity in a complex system. They will trust you with their health. You have earned that trust. You have put in the work. Now, go and serve your patients with the confidence, integrity, and compassion that this profession demands. Welcome to the profession. Thanks for watching this overview of the PEBC Study Guide. We hope these visual breakdowns help clarify your path to becoming a licensed Canadian pharmacist. If you found this video helpful, please help us out by hitting that like button and sharing it with your fellow students or study groups. And finally, make sure to subscribe to the channel so you don't miss out on more essential Canadian pharmacy exam tips and resources in the future. Good luck with your studies. You've got this.